Now let's begin with the review of genetics. Now in the first part I've divided it into three parts, and in the first part I'm going to talk about all the mnemonics that you had for Mendelian disorders. So first we need to quickly revise the Mendelian disorders and all the mnemonics with it. After that we'll go into the concepts of the non-Mendelian disorders, that is the second part of the review. And the third part I'm going to tell you all the diagnostic modalities in a quick overview so that you can cover all of those. Let's get going right away. When I talk about Mendelian disorders, you know there are 5 of these: autosomal dominant recessive, X-linked dominant recessive, and Y-linked. So let's start. When I talk about autosomal dominant, please remember that there is a very famous mnemonic known as "he has a very dominant and powerful father." So here you go. What is he has? One by one I'll take up. He has all the, he mein sab kuch, all the hereditary things will come. So what are the hereditary things that we have? Let's get going. Hereditary spherocytosis, hereditary hemorrhagic telangiectasia, and hereditary non-polyposis colon cancer. What is hereditary non-polyposis colon cancer also known as? It is known as the Lynch syndrome. So repeating once again, guys, what all is there? As I said, HE में hereditary spherocytosis, hereditary hemorrhagic telangiectasia, hereditary non-polyposis colon cancer or Lynch. So he हो गया. Now let's come to H. He has one disease of the brain, one disease of the heart. H से दो diseases. One is of the brain and that is known as the Huntington disease. One is of the heart and that is known as hypertrophic cardiomyopathy. Simple, one brain, one heart, Huntington, hypertrophic cardiomyopathy. He has a kidney. Everyone's heard of polycystic kidney disease. So can I place the autosomal dominant wala polycystic kidney disease over here? Common sense, I can. Right? He has a very, V से दो diseases हैं, V short form वाला diseases, VWD and VHL. What did I say? VWD and VHL, von Willebrand disease and von Hippel-Lindau syndrome. So von, he has a very von wala, von Willebrand disease, von Hippel-Lindau syndrome. Can you recall for me? VHL, which 3 alphabets, which chromosome gets deleted? Chromosome 3p gets deleted. So VHL, 3 alphabets, third chromosome gone. So ho gaya all the hereditary stuff, Huntington and HOCM, then autosomal dominant PKD and von wala diseases. So he has a very, next is going to be dominant. So now let's start, every alphabet has something. D is going to be muscle dystonia, muscle ke tone mein problem hai. So remember, there is a tone related problem. Then bone wala O se kya, which bone disorder comes to your mind? Osteogenesis imperfecta will definitely come to your mind, hai na? Then we have M for what I have to tell you in a lot of detail, Marfan's syndrome. Very, very important. This will get you a question. I will teach you in a while. M for Marfan's. I for intermittent porphyria. Please remember, there are lots of I's. Don't confuse. I'll keep telling you and reminding you all the I's. So I's are intermittent porphyria. Then N and N. N se actually both the NF1 and NF2 are going to come up over here. NF1 and NF2 both will come up. Next, there's another N as you can see over there. That N stands for Noonan syndrome. A stands for achondroplasia and T stands for tuberous sclerosis. So remember, muscle dystonia, osteogenesis imperfecta, Marfan's, intermittent porphyria, NF1, NF2, Noonan syndrome, achondroplasia, tuberous sclerosis. All of them are dominant. Almost the mnemonic is over. So dekho, he has a very dominant and powerful father. Khatam. What is powerful father? Remember, P stands for pseudo hypoparathyroidism. Pseudo hypoparathyroidism. Go to the main videos. I have discussed this under endocrinology also. Pseudo hypoparathyroidism. And he has a very dominant father. So everything with FA is gonna come up over here. 3 things with FA means there is a disease called familial adenomatous polyposis. There is a disease with FA. I have learned Li-Fraumeni syndrome. If you've seen the neoplasia chapter, you know now what is Li-Fraumeni syndrome, which mutation? It's the P53 mutation. And familial hypercholesterolemia. So what is FA of father? FAP, familial hypercholesterolemia, and we have Fraumeni syndrome. He has a very dominant and powerful father, out of which this dominant ka M is going to get you questions. Marfan syndrome is very important. So remember, Marfan syndrome is a disease which involves chromosome 15 and a gene called fibrillin 1 gene is defective. Repeating, which gene is defective? It is fibrillin 1 gene which is going to be defective. So repeating once again, it is chromosome 15 and fibrillin. 15 and fibrillin is going to be defective in it. So kya hota hai? What exactly does the patient have? Please note that there is a series of things that the patients are going to have, and the mnemonic for that is Marfan's disease or Marfan syndrome. Mnemonic hi yahi hai. Every alphabet will tell me something and I'll be sorted. So M, starting with M, M stands for the mitral valve prolapse. The M over here is going to stand for mitral valve prolapse. It is the most common cardiac problem that happens in these patients. What is the next alphabet? It is A. So A say there is aortic dissection. Again, aortic dissection, sounding aorta tearing. Of course, this is the most common cause of death. These patients will die because of aortic dissection. So repeating, M for what? Mitral valve prolapse. A for what? Aortic dissection. Next alphabet R, there is something to do with the eye involvement. There is retinal detachment. R for retinal detachment occurs. Okay, let's go with F. One of the most important. They have freely movable joints. They can move their joint in any direction, especially this one, the thumb joint that I've written. So freely movable joints will be there. Okay, let's move on to the A now. A is going to tell me two things. First, I'll show you a picture. There is a condition with A called arachnodactyly. What is arachnodactyly? Have a look at this. Arachnodactyly means very, very long fingers, like spider fingers. So what is arachnodactyly? Arachnodactyly is long spider fingers. And what is it with A? Another A which is recently very famous, that is the high arched palate. You know, I've tried to get you the same slides which I used in your main videos also, so that visual memory helps a lot. Now, the same notes I had made for you in your main videos. So I tried to get you similar notes so that same thing gets re-emphasized again and again. So Marfan, ab next ka alphabet hai N. What is going to be with N? These individuals are very, very tall. So because they are tall, we have called them 9 feet tall. So repeating all of this once again, when I'm dealing with Marfan's mitral valve prolapse, aortic dissection, retinal detachment, freely movable joints, high arched palate and arachnodactyly, and finally 9 feet tall, that is Marfan. Some people call it Marfan syndrome, some people call it Marfan disease. If you like to call it Marfan disease, please remember you are talking about disease. Dis means you are talking about dislocation of the lens. If you call it Marfan's disease, it is dislocation of the lens known as ectopia lentis, and you will ask me that okay, lens is dislocating where? Up, out, where? Up and out. Up and out. Up means supero and out means temporal. So where is it going to go? It is going to go up and out. It is a superotemporal dislocation. How do I learn it? Guys, Marfan. Fan matlab, fan is where? Fan is of course up on the ceiling. Fan kahan hoga? Fan will be up on the ceiling. And how does air go? Air is going to go all out. So temporal. So when the fan will move, air will go out. Na? So supero, because fan is up and the air is going out. So superotemporal is what we are going to notice. Repeating. So dislocation of lens occurs up and out, means they will ask you where does dislocation of lens occur, down and in inferonasal. So IN is going to occur in homocystinuria. This is going to occur in homocystinuria. So remember, inferonasal kahan hoga? Homocystinuria mein hoga, and superotemporal is going to happen in Marfan's. If you call it Marfan's disease, sorted. If you call it Marfan's syndrome, please remember this is associated with a sternum problem. Pigeon-chested or sternum problem is another thing that you have to know. I hope everyone's understood whatever Marfan's syndrome was having. But remember, the most common overall abnormality pucha. You'll say, ma'am, out of this big mnemonic, what will I select? Skeletal abnormalities. All those fingers wala, arachnodactyly, joint wala, all those, not heart and all those. Most common overall is going to be skeletal abnormality. In fact, in medicine, you study two signs. One is the Steenberg sign, one is the Walker sign. Bahut simple hai. When we say Steenberg sign, tell me something. Steenberg sign is the sign in which I will see the thumb coming out. Steenberg sign is when I will see the T for thumb coming out. If you tell them to close their fist, you will see that the thumb will be coming out like this. There is a thumb coming out because their fingers are very, very long. Na? And what is the Walker sign? W for W. Walker is the wrist sign. They can hold their wrist between their thumb and their index finger. So they are like blessed people, very, very thin. So they are going to hold their wrist with the thumb and the little finger. That is what is Walker sign. So simple. Steenberg sign में T याद रखना because that is the thumb sign. And then when we talk about Walker sign, that is going to be the wrist sign. Simple. That is all that you see in Marfan's. Very important. Autosomal dominant disorder. He has a very dominant and powerful father is done. Now let's begin with the next part, and that is the mnemonics of autosomal recessive disorders. I'm going to place a big fat order for autosomal recessive disorders. And what is that big fat order? That big fat order is of pasta and fried rice. Instead of rice, I'll just use the Hindi of rice, and that is chawal. So that is your mnemonic. I am placing a big fat order, so big facts for big fat order of pasta and fried chawal. So let us start. So let us start with pasta first. As you will study, the first two diseases are enzyme deficiencies, phenylketonuria and alkaptonuria. I hope you remember they have one very famous urine problem. Phenylketonuria is going to result in a mousy or a musty odor in the urine. There is a mousy or a musty odor in the urine, which is very characteristic for phenylketonuria. Whereas for alkaptonuria, it is kala urine, it is black urine, but urine is going to become black on standing. Patient does not pass black color urine. Urine, after coming out of the body, after coming in contact with the air, it turns black. So have a look at this picture. You will pass this in the patient is going to pass this, the urine is normal, and then it's going to turn black on standing. So please remember, black urine on standing is what is seen in alkaptonuria. Not only that, alkapto is many other things which are kala. There is going to be involvement of the cartilage is going to go black. Then you can see the nails also are going black. So why are they going black, guys? Asking you a little bit of biochem over here. What is the process? What is getting deposited? Homogentisic acid is what is giving the black color. So remember, there is going to be black urine, there is black cartilage, there are black nails. That is what you see in alkaptonuria. So phenylketonuria has a mousy or a musty bad odor in the urine. Alkaptonuria has kala urine, kala everything. Okay, these were two enzyme problems. The other two are hemat problems, sickle cell anemia and thalassemia. So pasta ka order complete. Pasta order is complete. Two of them are enzyme problems. Two of them are going to be sickle cell thal hematology problem. What is fried? Fried is, the name is only telling me Friedreich's ataxia. So the name is telling me ki acha fried se there must be Friedreich's ataxia. Sorted. Pasta is done. Then fried ke baad what? What fried are you finding? You're finding fried chawal. So that is your next order that you have to place, and that is pasta fried chawal. So what is C? C stands for cystic fibrosis. C is going to stand for cystic fibrosis. H is going to stand for lot of things which I want to teach you, but I'll first start one by one. Dekho, it stands for iron overload. As soon as I say hemochromatosis, iron overload, next question coming to my mind is copper overload. So let me write that also. The W is obviously going to be copper overload. This means it's going to be Wilson's disease. If H is hemochromatosis, so then W is Wilson's disease. That is also sorted. H is not over. This is also going to be associated with homocystinuria. And it is associated with a hemophilia. But kaunsa wala hemophilia? Right now I'm teaching you hemophilia C. So remember CH yaad rakhna. C is for cystic fibrosis. But even when you go to the H, everything in H is also to do with C. Matlab hemophilia पूछा तो hemophilia C. Homo what? Homocystinuria. Hemo what? Hemochromatosis. तो याद रखो, देखो hemophilia C, homocystinuria, hemochromatosis, HC is going together. Okay, then what is with A? We have an enzyme deficiency called alpha-1 antitrypsin deficiency, which is very famous. We have more A's coming up our way, which are questions. Remember, albinism and adrenal hyperplasia. Both of these are previous year questions. Albinism and adrenal hyperplasia are autosomal recessive, and lysosomal and glycogen storage disorders are autosomal recessive. So repeating the pasta, fried rice or fried chawal. C for cystic fibrosis. H is going to be everything to do with C. So hemophilia C, homocystinuria, hemochromatosis. A for alpha-1 antitrypsin deficiency, W for Wilson's disease, A for albinism as well as adrenal hyperplasia, L for lysosomal and glycogen storage, all storage disorders. I'll come to exceptions also in those lysosomal. So in that big order that you placed, finally pasta done, fried chawal done, so big fat order kya hai? What is big facts? These are something that you've already studied in neoplasia. These are all DNA repair defects. Can you recall for me what all DNA repair defects were there? B was for Bloom syndrome. Then FA jodo, it was Fanconi's anemia. Then go with AX, that is ataxia telangiectasia, ataxia telangiectasia. And then X alone is going to be xeroderma pigmentosum. Let's do a recap of this mnemonic. I know it can be a little overwhelming because thoda lamba mnemonic tha. So remember, B is going to be for Bloom syndrome. FA is going to be for Fanconi's anemia. AX is going to be ataxia telangiectasia. X alone is going to be xeroderma pigmentosum. All these are autosomal recessive. So repeating, whether it is a big fat order of pasta and fried chawal, all of these are going to be autosomal recessive ka examples. Now out of these, you will get a question of some of these. Lysosomal storage disorders पूछेंगे तो जल्दी से, do you want to revise first all the जल्दी करके, should we just revise the enzyme deficiencies and then I'll come to those? Okay, so let's start. When I talk about Tay-Sachs disease, the way you write Tay में क्या आता है? A comes, so there's alpha, and Sachs sounds like 6. It sounds like 6. 6 matlab hexose. So alpha hexosaminidase is going to be deficient. Alpha hexosaminidase deficiency. And please note that Tay-Sachs disease shows you these kind of pictures. There are huge neurons. There are going to be ballooned neurons, and these balloon neurons are, why are they so big and balloony? Because they have fat. They are oil red O positive. Next, it shows you that onion skinning, the round and round, you get to see the onion skinning appearance of which organelle? Common sense, lysosome. Lysosomal storage disorder hai to lysosome ka problem. And what is this ophthalmology finding that you're seeing over here? We see the very famous cherry red spot at the macula of the eye. Cherry red spot is seen at the macula of the eye. Please note, in Tay-Sachs disease, usually the spleen is not palpable, and that was a recent NEET PG 2023 question. Usually the spleen is not palpable. Spleen nahi hota. So why am I saying that? Because where can you pick the spleen? Where can you pick the spleen? So remember, I can pick up the spleen in Niemann-Pick disease. That will tell me you can, yes, you can see the spleen, you can palpate the spleen, because spleen will tell me sphingomyelinase deficiency. How nice. I am saying Niemann-Pick may pick the spleen, and SP matlab sphingomyelinase deficiency. What do you see in Niemann-Pick disease? In Niemann-Pick disease, we are not only going to see the picking of the spleen, but please remember, this also shows you the zebra body. So man has gone to see the zebra. Man has gone to see the zebra. You can see these black and white lines that are there. Classical, no description needed. So Niemann-Pick disease mein number 1 we pick the spleen, so splenomegaly hota hai, and man has gone to see the zebra, so zebra bodies are seen. Next we come to the Gaucher's cell. सबसे पहले तो Gaucher's. See, I have written Gaucher's as gouge. Why gouge? Because these patients usually come to you with bone pains. This was again a recent NEET PG question. Ouch से याद रखोगे. Patients are gonna have bone pain. And what is the enzyme deficiency? Glucocerebrosidase. अब एग्जाम में there's a lot of confusion. कहाँ पे glucocerebrosidase है, कहाँ galactosidase है, alpha galactosidase, beta galactosidase. I'll sort it out. देखो, when you're writing Gaucher's, you can very well see Gaucher's has a U in it. If it has a U in it, you can't mark galactosidase. You have to use U वाला sound. Glucocerebrosidase लिखना पड़ेगा. Because it has U in it, you will also have to write U in it. Glucocerebrosidase. Whereas the ones which have galactosidase, वो AA वाला sound है, तो उनमें AA वाला diseases रखना ना. Fabry's disease, Krabbe's disease, इनमें U नहीं है, they don't have a U, so keep the AA over here. Galactosidase, Fabry, that is Krabbe. But now the confusion is alpha galactosidase or beta galactosidase. So simple. Alpha is gonna be Fabry's disease because there is only alpha, means there is one B in it. Fabry has one B. Krabbe has two B's. It has two B's. So that is going to be the B ज़्यादा है. So that is going to be beta galactosidase. So Fabry में there is one B. So I'm only going to keep simple alpha galactosidase रखेंगे. Whereas Krabbe is going to have lots of B's in it. So I will have to keep the beta galactosidase over here. Now there's no confusion. Now moving forward, there is something known as, before I go on to the next ones, coming back to Gaucher's, I just told you that these patients present with bone pain, gouge, Gaucher's, glucocerebrosidase. This has been a hat trick in NEET PG and FMG with back-to-back sessions showing you this. Remember, Gaucher's disease is going to show you the very, very famous crumpled tissue paper appearance. It shows you the famous crumpled tissue paper appearance. And this is the most famous image. You can see those line, basically how a tissue has been crumpled. So if you crush a paper, you will get those lines in it. That is what you see as the crumpled tissue paper appearance. So Gaucher's is done. Now coming to MLA. What is MLA? Metachromatic leukodystrophy shows aryl sulfatase deficiency. Metachromatic leukodystrophy, aryl sulfatase deficiency. Now we come to Hurler and Hunter. One of them is, both of them are to do with iduronidase, iduronate. तो कैसे पता लगेगा? One is alpha L iduronidase, means when in talking about Hurler में ये L वाला आएगा, alpha L iduronidase. Whereas when I'm talking about Hunter, you will say Hunter. Hunter की जगह Hunter, because iduronate 2-sulfatase will come over here. Best way of learning, there's no other way possible. So remember, Hurler में L आता है, so there is going to be alpha L iduronidase deficiency. Hunter has Hunter, so there's iduronate 2-sulfatase deficiency. So these are all the deficiencies. Repeating, Tay-Sachs में alpha Sachs means alpha hexosaminidase. Niemann-Pick, pick the spleens, sphingomyelinase and splenomegaly is seen. Gaucher's, ouch for bone pains, and Gaucher's U आता है, तो glucocerebrosidase is there and crumpled tissue paper appearance is seen. Fabry has single beta, so alpha galactosidase. Krabbe has double beta, so beta galactosidase. MLA, metachromatic leukodystrophy, aryl sulfatase. Hurler has L, so alpha L iduronidase deficiency, and Hunter has 2, so 2-sulfatase deficiency. These are all of your lysosomal storage disorders, and where have I studied them? All of them are autosomal recessive, and now comes the twist in the story, except 2, and those are going to be Fabry's disease and the Hunter's disease, except for Fabry's and Hunter's disease, because these two are going to come in the next part that I will teach you, and that is XLR. So Fabry's and Hunter's don't come under autosomal recessive, they come under XLR, and that is what I shall study. I hope everyone's okay with autosomal recessive, the big fat order of pasta and fried chawal, yes? Now coming to XLR. XLR mein pehle to you will have to learn the rule. The rule says that in most of the cases, usually, most of the cases, not always, but most of the cases, the disease will happen in the male gender and the carrier state will happen in the female gender. Repeating, the disease will happen in the male gender and the carrier state will happen in the female gender. So we have, because यहाँ पे थोड़ा male female has started, so you have to be very, very wise. You have to be very wise in terms of there should not be any gender discrimination. So wisely mnemonic banana. Wise A, B, C, D, E, F, G, H. What is your mnemonic over here? We have a mnemonic which is known as Wise A, B, C, D, E, F, G, H, out of which you already know that Fabry's and Hunter's will come here. है ना? Fabry's and Hunter's will come. Let's start. When I say Wise, the Wise stands for, Vis stands for Wiskott-Aldrich syndrome. Common sense again being put over here. So the Wise is going to stand for Wiskott-Aldrich syndrome. Then A and B together means hemophilia A and B. A and B together means hemophilia A and B, which makes me want to write, where did I study hemophilia C? Hemophilia C was CAR, autosomal recessive. This was different. Hemophilia C was autosomal recessive, whereas hemophilia A and B are going to be XLR. There's another thing with B, that is Bruton's hypogammaglobulinemia. C के साथ there are a lot of things. We have studied a disease called chronic granulomatous disease, पढ़ा है ना in the second chapter, in the rapid review also we've done. Then there's a color blindness, that is the red-green color blindness, and because I'm talking about the eyes, I will also want to talk about ocular albinism. Please note, albinism alone was autosomal recessive. A for A, albinism was autosomal recessive, but ocular albinism is going to be XLR. Ocular albinism shall be XLR. ठीक है? Moving on, we have two muscle dystrophies, Duchenne's muscular dystrophy, Becker's muscular dystrophy. So Wise में A, B, C, D तो हो गया. Now coming to E, E से I could not make anything, so it is an enzyme problem, that is HGPRT deficiency, Lesch-Nyhan syndrome. So remember, Lesch-Nyhan syndrome comes with E. With F, पहले तो remember, you know there is Fabry's, and H के साथ there is Hunter's. Don't we know this? With F we have Fabry's and H we have Hunter's. We have another thing with F, that is Fragile X syndrome, which is common sense. If something has X in it, of course it is going to come under X-linked. It could be X-linked recessive also, it could be X-linked dominant also. So X chromosome ही है, the name has a fragile X syndrome. So it can be XLR, it can be XLD, but XLR is more common. ठीक है? Now coming to the last one, that is G, and that is G6PD deficiency anemia. So now we are done with the entire mnemonic. This is a Y is ABCDEFGH mnemonic. Y is for Wiskott-Aldrich syndrome, A and B for hemophilia A and B for Bruton's, C for CGD, color blindness and ocular albinism, D for DMD and BMD, the two muscle dystrophies, E for Leishnihan, F for Fabry, Fragile X, G for G6PD, H for Hunter's. XLR done. Coming to the next, XLD. This works as D, 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 D. What do I mean by that? Please note, X-linked dominant disorder, dad will give the disease to all the daughters. When they say that there is a dad, always remember, if the dad has given the disease to all the daughters, you are dealing with an XLD, matlab dad, daughter, DDD. And if the dad has given the disease to all the sons, तो sons के पास तो Y chromosome जाता है. Put common sense ना. Dad has X and Y chromosome. Father is X and Y. Y chromosome has to go to the sons and X chromosome has to go to the daughters. So if the X chromosome will have a problem, जैसे XLD है, X chromosome has a problem, so the daughters will get it. If the Y chromosome will have a problem, then all the sons will get it. So simple. If the dad is giving the disease to all the daughters, it is gonna be XLD, and XLD ka mnemonic is simple, Ravi. What is Ravi? R for Rett syndrome. It's a neurological problem, Rett syndrome. A for Alport syndrome. V for the hypophosphatemic or the vitamin D resistant rickets, and I for incontinentia pigmenti. Please don't get confused with these I's. Go all the way back to the first thing. There was something with I right in the beginning. If you remember, when he had a very dominant and powerful father, autosomal dominant maybe I tha, that was intermittent porphyria, that is autosomal dominant. Now I'm talking about the next one, and that is incontinentia pigmenti, that is XLD. So XLD ka mnemonic kya hai? Ravi. Remember, Ravi stands for what? Ravi is the sun. So basically what I want to tell you is that sun and continents ko saath mein rakhna. The sun, planets and continents, keep them together. So Ravi wale mnemonic mein please keep the continent, not intermittent porphyria. You will keep incontinentia pigmenti with the sun. That is just a way of learning, okay? So remember, we have Rett syndrome, Alport syndrome, vitamin D resistant rickets, and then finally we have the incontinentia pigmenti. With one word of caution over here, when I'm talking about Alport syndrome, it can possibly have all the inheritances. It can have autosomal dominant, recessive, XLR, XLD, all, but I had to make you mark most common. So most common XLD, but otherwise it can have all the inheritances possible. Coming to the last one is the Y-linked or the Hollandric inheritance, and please note that Y chromosome matlab androgen na. So Y-linked or Hollandric inheritance, this is a disease which is going to go from the dad to all the sons. Common sense na, Y chromosome to will go in all the males only. So dad to all the sons is gonna go, and there is only one example that you have to know: hairy ears, lots of hair, hypertrichosis, lots and lots of hair, या फिर hairy ears will be written. Basically something to do with lots of hair. And common sense, men are very hairy, so all these hairy things will go towards men only, na? So Y-linked is going to be Hollandric inheritance. Mendelian disorders comes to an end. Do you want to quickly test yourself? What is sickle cell anemia? Sickle cell anemia was a part of which mnemonic, guys? Pasta, fried chawal. So this was autosomal recessive. Okay, moving on to the next one. What is hemophilia C? That's a trick question. Hemophilia C was autosomal recessive, but hemophilia A and B were X-linked recessive, है ना? So hemophilia C was autosomal recessive. Again, the pasta, fried rice, fried chawal mnemonic. Coming to the next one, let's see if we can answer this. There's a 22-year-old man who has features of arm span greater than height. So arm span is greater than height. Sublux, lenses, dislocation of lens. Marfan's has come in my mind. Aorta may be problem, aortic dissection bhi ho sakta hai. Marfan's has come into my mind, and I know which gene am I selecting out here. Chromosome 15, fibrillin 1 gene is my answer. When NEET PG has made a hat trick, I cannot ignore it. Where do you see the crumpled tissue paper appearance? This crumpled tissue paper appearance is seen in the very famous Gaucher's disease. Kaunsa deficiency? Glucocerebro or galactosidase? So Gaucher's has a U. So what will you say? Glucocerebrosidase deficiency. Excellent. Coming to the last one. father has an XLD disorder, how many percentage of daughters will be affected by the disease? What did I tell you? The dad in an XLD disorder, the dad will give the disease to how many daughters? To all the daughters. So batao, the dad will give the disease to all the daughters means what percentage of daughters are going to get the disease? Common sense. XLD, X chromosome from dad will go to all the daughters. If they would have said dad has XLD, how much percentage of sons will be affected? Daughters to 100% affect hoga. But if sons would have been asked, you'll say, ma'am, X chromosome from the father doesn't go to the sons. Father to son ko Y chromosome dega na, not X chromosome. So sons will be 0%. If XLD disorder hai, all the daughters, 100% daughters and 0% sons will be affected when there's an XLD disorder. And that marks the end of the Mendelian disorders. What are we going to move on to next? Next, we are going to go ahead and talk about the non-Mendelian disorders. So let's quickly move on to the second part. As we had decided, we had divided genetics into three parts: Mendelian, non-Mendelian, a little bit of chromosomal if we can touch upon it, and then we'll be going on to the diagnostic things. So now we are talking about non-Mendelian disorders. When we say non-Mendelian disorders, please note these are the four things that are going to come under it. Please note very carefully. Number one, mitochondrial inheritance. When I say mitochondrial inheritance, there is a rule that you have to know. We all have mitochondrial DNA. Did you know? एक तो normal DNA है, nucleus वाला DNA. We also have another DNA known as a mitochondrial DNA, and mitochondrial DNA is going to be coming from the mother only. Mitochondrial DNA has maternal inheritance. It has maternal inheritance. Very, very important. So only the mother gives us mitochondrial DNA. Pick up the phone, thank your mother. All your mitochondrial DNA, 100% of your mitochondrial DNA has come only from your mother. Your father has not given any mitochondrial DNA. Father has other contributions, but mitochondrial DNA may no contribution. So imagine if the mother has a mitochondrial DNA disease versus if a father has a disease in the mitochondrial DNA. You will say, ma'am, if mother has a disease, mother will give the disease to all her children. Whether it is a boy or a girl, mother gives mitochondrial DNA to all her children, so the disease will also go to all the children. Father does not give the mitochondrial DNA to any child. So father's disease will not go to any child. So is the rule right in front of me? Can I say the rule of mitochondrial diseases is that there is number one, mother to all, father to none. Mother will give the disease to all the children. Father will give the disease to none of the children. And what are the examples? Let's get going. The most common one that you have, guys, the most common mitochondrial inheritance is MELAS. Do you know MELAS is actually a short form. What does MELAS stand for? MELAS is going to be M for mitochondrial encephalopathy. So ME ho gaya mitochondrial encephalopathy. LA is going to be lactic acidosis and S is going to be stroke. So what is MELAS? The most common mitochondrial disorder. Patient will come. They will say there is a mother. Mother has encephalopathy. Mother has lactic acidosis. Mother has stroke. After the mother, all her kids also have the same problem. Encephalopathy, lactic acidosis, stroke. Mother ko bhi hai and all the kids have it. You know you're dealing with mitochondrial diseases. You know you're dealing with MELAS. Coming to the next, अब ये जितने भी short forms है, CPEO, LON, NARP, LEAG, all these come under it. What is CPEO? CPEO stands for Chronic Progressive External Ophthalmoplegia. You will be studying this under Ophthal, of course. Then there is something called LON. LON stands for Leber's Hereditary Optic Neuropathy. Optic nerve, another ophthal related thing. Then there are some unheard of things, like for example, we have Leigh syndrome, Pearson syndrome, Kearns-Sayre syndrome, and even a disease called NARP. Please note, NARP can be seen. You can very well notice NARP is also full form only. There is going to be neurogenic ataxia. There is neurogenic ataxia and there is retinitis pigmentosa. There is retinitis pigmentosa. So there's also basically neuropathy. Neuropathy hai, ataxia hai, retinitis pigmentosa hai, to NARP ho gaya. So all these short forms that I'm talking about over here, these are really going to help me. That is short form wala things are going to be mitochondrial disease, and most likely to get a question is going to be on MELAS. There's one more short form which I want all the students of the Central Institute exam aspirants to know. What is MRF? MRF is M. pellito again. Patient will have myoclonus. There is myoclonus, E for epilepsy, myoclonic epilepsy होगा, तो ये तो clinical हो गया, myoclonic epilepsy, M and E. What is RRF? RRF is pathology. They will show red ragged fibers. Can you all see the picture below, and can you see that there are some red fibers that you're seeing? Yes, these are red ragged fibers. So myoclonus epilepsy with red ragged fibers. This is also mitochondrial disease only, guys. And this on an electron microscope shows you picture number 1, picture number 2. This on an electron microscope, this looks like that old age phonographic records. I don't know how many of your parents might have stored them and kept them till date, but old age में जो वो phonographic record था on which they used to listen to music, yes, phonographic record जैसा लग रहा है. And what are these boxes? These are looking like just how you park in the streets of Delhi, just random appearance of parking. This is known as the parking lot. This is the parking lot appearance that you have. So repeating, when we say MRF, it is a mitochondrial disorder. There is myoclonic epilepsy and there is RRF. There is going to be red ragged fibers. And these red ragged fibers, under the microscope, you will see phonographic record and parking lot appearance. So the first non-Mendelian disorder is done, or you can say mitochondrial diseases are done. The next one that I'm going to go on to is trinucleotide repeat disorders. Now, when I say trinucleotide repeat disorders, something is going to repeat again and again and again. CGG, 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 CGG. It will go on and on and on repeating. So now, the diseases will depend on where is the repeat occurring. Is it occurring in the intron or is it occurring in the exon? So CGG, 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 trinucleotide. मतलब देखो CGG. Is it a trio है ना? It will keep on repeating. हो गया problem. That is a big time problem. So please note, only out of these, I will first want to tell you a mnemonic called hunting in a cage. What is hunting in a cage? Because that will remind you that Huntington disease, when you're talking about Huntington disease, the repeats that it shows you are the CAG repeats. It shows you the CAG repeats, and are these in the exon or the intron? So that's also in front of you, hunting in a cage. So that is going to be in the exon. Ho gaya na easy? Hunting in a cage means Huntington disease is going to show you CAG repeats, and that too in the exon region. Done. Rest all of them are going to come under introns. Easy. So for Fragile X syndrome, the repeats are CGG. For Fragile X syndrome, it is CGG. The next disease, as I read, it is myotonic dystrophy. I realize दोनों words में T is in the center. Myotonic has a T in the center. Dystrophy has a T in the center. So now what I'll do, from above, I had CGG in Fragile X. Now I change the center. I now make it CTG. When myotonic has a T, dystrophy has a T. So instead of CGG, I will make it CTG. What is Friedreich's ataxia? Very famous. Friend गाना गा रहा है. Friend is singing. गाना गा रहा है. Ga means GAA repeats. Friend गाना गा रहा है. So GAA repeats. Repeating. Fragile X syndrome is CGG. Center में if you put a T, CTG, that becomes myotonic dystrophy. And Friedreich, friend गाना गा रहा है. So that is going to be GAA repeats. All of them are in the intron, whereas hunting in a cage, Huntington disease is in the exon. Out of these, the ones that you have to know in detail is definitely Fragile X syndromes. Which chromosome do you think is going to be Fragile X syndrome? Let's put a little bit of common sense into it. Fragile X syndrome is of course going to be chromosome number X. Common sense. What gene am I talking about? This is the FMR1 gene. And in the FMR1 gene, it is going to show you which repeats. I've just told you it shows you CGG repeat. So the next question is, kitna repeat? 5, 10, 20, 40,000. How many repeats have to be there? So remember, till the time it is repeating less than 55 times, we all have this. CGG repeating for up to 55 times is normal. CGG, CGG, CGG 55 times tak normal. When it crosses 55 to 200, that is known as a pre-mutation, and that is not Fragile X. Mind it, that is Fragile X tremors and ataxia. That is known as Fragile X tremors and ataxia. Patient has tremors, ataxia, not Fragile X syndrome. Only when CGG crosses 200, that is a proper mutation, and that is when the patient is going to have Fragile X syndrome. That is when the patient has Fragile X syndrome. So repeating, up till 55 times CGG, good to go, we all have it, nothing to worry. 55 to 200, pre-mutation hai, kind of it's there, but it's not Fragile X syndrome, it's Fragile X tremors and ataxia. Whereas once it crosses 200, matlab take home messages for Fragile X syndrome, there should be a crossing of 200 repeats to call it Fragile X. And do you know that with every generation, these repeats are increasing? Please note that the repeats are increasing with each generation. So if someone's grandparents had 500 repeats, parents will have 1000, then grandchildren will have 1200, aage 1500. So with every generation, it's increasing, becoming severe and severe and severe. And this situation is known as the Sherman's paradox or anticipation. This is known as Sherman's paradox or anticipation, that is, the repeats are increasing with every generation. Very important point that you have to know. Let's do the clinical features. Remember, a patient of Fragile X syndrome will have mental retardation. Previous year question was that the IQ is in the range of 20 to 60. This has come in the previous year NEET PG. Exact IQ kitna hota hai? The range of 20 to 60. If you see, I see a lot of face problem. Many people call him ke wo PK wala, Amir Khan wala face. Some people say Captain Marvel wala face. So your wish, whatever you feel looks like. But he has a lot of face abnormalities. Means you can see there is a long face that you have. Then there are large ears that are there. And there is a large mandible that is there. See how I've drawn his face? Repeating, we've got a long face out here, we've got large ears, and we've got a large mandible. That is exactly what you see in the face. But is that the most characteristic point about him? No. What is the most characteristic feature? The most characteristic feature is macroorchidism, large testicular size. This has been a question in the previous year. They asked you, what is the most characteristic feature of Fragile X syndrome? Options were long face, large ears, large mandible, large testes. Everyone said, ma'am, everything is seen in Fragile X. But they asked you characteristic, na? So the most characteristic is going to be large testicular size. Very important. Lastly, how will you do the diagnosis? What is the diagnosis of choice? We do PCR. We do polymerase chain reaction as the diagnosis of choice. Very good. If a simple question comes, what is the diagnosis of choice for a case of Fragile X syndrome? You will do PCR. But if PCR fails, PCR says, no, there are so many repeats, I can't detect it. If PCR fails, what are you going to do? You shall be doing Southern blotting. ठीक है, पहले तो रट लो. If first thing I will do PCR, if PCR fails, I will do Southern blotting, because you know immediately I'm going to ask you the different type of blotting techniques. Can you tell me from biochemistry what are the different type of blotting techniques? Southern blotting, Northern blotting, Western blotting. Remember, roti, dosa, pizza wala mnemonic. So when there is Southern blotting, South में क्या खाते हैं? South में dosa is very famous, very tasty also. That is DNA detection. North mein what we guys eat is usually roti, so that is going to be RNA detection. And West mein the even more tastier pizza. This means there is going to be protein detection. So please remember, South mein dosa, so there is DNA detection. North mein roti, that is RNA detection. West mein pizza, so there is protein detection. You will say, ma'am, why are you ignoring the East? Not a very common question, but I want to tell you that Eastern blotting exists. There is an Eastern blotting which no one reads. This I want all the Central Institute exam aspirants to know. This is going to detect post-translational modifications. This is going to detect all the post-translational modifications. That is going to be by Eastern blotting. So something very hi-fi is kept for Eastern blotting. If you noticed, by now, I was only talking about Fragile X syndrome, man, macroorchidism, male wala face. What about females? There's an update. Female carriers of Fragile X syndrome show what? Female carriers of Fragile X syndrome show premature ovarian failure. That's a line that has been added in Robbins, which all of you have to know. That is, premature ovarian failure is seen in the female. So whatever I told you up till now were the characteristics of a male: long face, big ears, big mandible, big testes. Of course, males mein hoga. But what about females? Females mein ovaries effect hoga. Common sense, male mein testes, to female mein ovary. And that is POF, premature ovarian failure, is seen in the carrier females. I hope that's okay. We can have a quick question over here. Find the incorrect match with regard to the disease and the trinucleotide repeats. For Fragile X syndrome, is it CGG? Correct. For myotonic dystrophy, is it CTG? Correct. For Friedreich's ataxia, friend Gana ga raha hai is also correct. But for Huntington, is it GAG? No, hunting in a cage. Hunting was supposed to be CAG repeat. So that is the incorrect match. That is the answer that you have. So the second non-Mendelian disorder is also sorted. Mitochondrial done. Trinucleotide done. Go on to the third one, that is genomic imprinting. What do you understand by genomic imprinting? Imprinting matlab chup. That is silencing. Imprinting basically means to become silent. That is what we call as silencing. So I'm going to give you two examples. You know the diseases that I'm going to talk about, Prader-Willi syndrome and Angelman syndrome. So I've got you these two diagrams so that you have a little bit of orientation. Pehle to please note what have I written. I have written that there is chromosome number 15 over here, chromosome number 15 here. We all know every chromosome is in the pairs. So that means one has come from the father and one has come from the mother. So here one from father, one from mother, one from father, one from mother. ठीक है, normal हो गया. In SNORP gene, there's one thing called SNORP gene. Mother has given SNORP gene, father has given SNORP gene. There is something called UBE3A gene. Mother has given UBE3A gene, father has given UBE3A gene. Okay. Please note that when I'm talking about the SNORP gene, agar SNORP gene mein problem aaya, I will be dealing with Prader-Willi. If UBE3A gene mein problem aaya, I will be dealing with Angelman. So look at the last words of these. SNORP is P, so Prader-Willi. UBE3A is A, so that is Angelman. Of what problem? Please note, there is going to be maternal imprinting and paternal deletion that you see in a case of Prader-Willi. How do I learn what is imprinting? Matlab silence. What is silenced and what is deleted? Simple. There are two kinds of students in class. One student who is silent and one student who is just going to bunk, deleted. So which student is silent and which student is bunking? Maternal silent, paternal bunking, or ulta? So remember, in Prader-Willi, you shall always remember that the papa's region is deleted. The papa's region is going to get deleted. Papa region deleted. So if I know कि अच्छा papa deletion है, तो then obviously mother is imprinted, है ना? Papa is deleted, this means mother is imprinted. Angelman में opposite. In Prader-Willi, if papa was deleted, this means in Angelman, mother is going to be deleted. There is going to be maternal deletion and there is going to be paternal imprinting. Life becomes so simple. All that you have to learn is papa's region is deleted. So if papa is deleted in Prader-Willi, maternal is imprinted. And Angelman mein ulta. In Prader-Willi, if papa was deleted, in Angelman, mother will be deleted. Sorted, everyone? Chromosome is the same, but you know the difference is imprinting and deletion you have done. Now you need to know their clinical features. Both of them are going to be having mental retardation. Whether Prader-Willi or Angelman, both have mental retardation. I have learned one mnemonic. Prader-Willi is a chota mota bacha. What do I mean by chota mota bacha? Means this is going to be short stature and obese. Prader-Willi is going to be a short stature and an obese bacha that you have. Okay? Other than that, now they also ask you, why is this child obese? Because there is too much of ghrelin production that happens. The reason for obesity is ghrelin production. So remember, there is a chota mota bacha that you have to consider in Prader-Willi. What about Angelman? Angelman mein, guys, please remember, we have something known as sari. Mothers are angels. I'll repeat. Mothers are angels and mothers usually wear saris, na? So sari mnemonic mein, what are you going to know? These are the 4 things that you have to know out here, which means patient has S for seizures, A for ataxia, R, so I think everyone knows mental retardation, I for inappropriate laughter. So seizures, ataxia, mental retardation, inappropriate laughter. They will keep laughing like an angel. That is why they are known as happy puppets. They are referred to as happy puppet. So repeating once again, when I talk about Angelman is what? Sari. Mothers are angels, mothers wear saris, na? So seizures, ataxia, retardation and inappropriate laughter. So how I have learnt is Prader-Willi is chota mota bacha and Angelman is gonna be a happy puppet. Story finished. Non-Mendelian disorder done. One last left, and that is gonadal mosaicism. What I call it is the pop-up. Pop-up means what? That all the generations are normal. when I say all generations are normal, I will say that the parents, the grandparents, and everyone in the family is basically gonna be normal. But then there is a child affected. So it's like everyone is like shocked that, okay, when everyone in the family was normal, then why is this child born with the disease? I'll give you an example. Child is born with osteogenesis imperfecta, or child is born with tuberous sclerosis, osteogenesis imperfecta, or tuberous sclerosis. So if they say that when no one in the family has any of these problems, why are these children having these problems? So now think logically. Let's say when I'm saying the parents are normal, means that the sperm and the ova were totally normal. And when the sperm and the ova fused, the zygote was also totally normal. Sperm be normal, ova be normal, zygote be normal. So what is going to be the problem? This is going to be a mutation after the zygote formation. This is a post-zygotic mutation that occurs, and that is the question you shall get. What is the level of mutation in gonadal mosaicism? Gonadal mosaicism ka mutation is going to occur at the post-zygotic level. That is very, very important, and that is why this child has ended up getting affected. So is that okay? You will get a disease that parents, grandparents, great-grandparents, uncles, aunts, everyone is normal, but this child has suddenly popped up. That's how I was calling it pop-up disease. Someone suddenly pops up with a disease. Why? Because the genetic mutation has occurred at the post-zygotic level, after the zygote formed. Two very famous examples for this are going to be osteogenesis imperfecta and tuberous sclerosis, with which we have finished the second part that we had promised, that is non-Mendelian disorders, also sorted. Let's move forward. Now let's begin with the next part of the genetic disorders, and those are the chromosomal disorders. Now under chromosomal disorders, you know we're going to talk about 5 main things: Downs, Petau, Edward, Klinefelter, and Turner's. So let's dedicate 1 to 2 slides to each one of them, and let's get going with all the exam going questions that are important for all of you. So first question from my side to you is, what is the most common trisomy? I know many of you will be answering trisomy 21, and I want to tell you, hang on, that is not the correct answer. The most common trisomy is trisomy 16. But when is trisomy 21 the most common? Remember, that is the most common trisomy which is compatible with life, because you will see so many patients of Downs and all, right? Trisomy 21. But you don't really see patients of trisomy 16 in your day-to-day practice because it is not compatible with life. They're usually abortions, spontaneous abortions or intrauterine deaths. But theoretically, it is the most common trisomy to occur. Okay? So if this is the question, you mark trisomy 16, but if they ask you in terms of compatibility with life, it is trisomy 21. And that is what I'm starting with. I'm going to tell you the 2 things: clinical features and complications of Downs, that is trisomy 21. Let's get going. This is a case of Down syndrome. So what all do you see in Down syndrome? I think everyone knows that this is the most common cause of mental retardation, Downs, right? Everyone is aware of it. Let's look at head to toe what are all the features that a Downs baby is going to show us. So first and foremost, you will say all of them tend to have an open mouth. They always tend to keep their mouth open. Why is their mouth open? Because look at their tongue is coming out. There is macroglossia. The size of their tongue is very, very large. So please remember, number 1 point, they have an open mouth. Reason for open mouth is macroglossia. So basically their tongue is coming out, and other than that, you will notice their chin is very, very small. That small chin situation is known as micrognathia. So simple. Macroglossia, macro means the tongue is too big and coming out. Micrognathia means, micro means the chin is very small. So these are to do with all the mouth related things. What about the eyes and the nose and the face part? So they are said to have mongoloid faces. And what are mongoloid faces? If I ask you, you will see that they focus on their on their eyes. They have oblique palpebral fissures. So the first thing that all of them have are going to be oblique palpebral fissures. Their eyes are oblique like that. And look at their nose. Their nose is very flat. So their nose out here, you will notice, is very flat. You know why is it flat? Because when you look radiologically, you will see that their nasal bone is not developed. It is nasal bone hypoplasia. So on ultrasonography, you can see this. The radiologist can see this in intrauterine life, that the nasal bone is not developed. So remember, this is known as the mongoloid facies. Repeating, what is it? There are oblique eyes and there's a flat nose. Okay, there's an open mouth, a big tongue, and a small chin. 5 features are done. What about the eyes? What will you see in ophthalm? We see the very famous Brushfield spots. So can you see these spots over here? Which part of the eye are they in? That is a question that you get in the ophthalm section. They are present in the iris. Okay, so this is also done. These are all the head and neck changes that you see in a baby of Downs. Now let's talk about their hand findings. What do you see in their hand? Please note, there's a very famous crease known as the simian crease. Can you see this? There's one single line that is going this way. Yes, so this is known as the single crease, and that single crease or single palmar crease, you know, on their palm you can see a single crease. Like all of us have two lines, they have a single crease, and that is known as the simian crease. Not just that, look at their tiny little finger. Look at their tiny finger. See, look at all your fingers. You have 1, 2, 1, 2. You have two creases on every finger, right? But look at their little finger. Their little finger has only a single crease. So again, remember, there is going to be a single crease that is present at the 5th digit. This is the hand-related finding. So palm has a single crease and little finger has a single crease. What about their toe? You can see the gap over here. It looks as if the child is wearing a sandal or a slipper. So that is known as a sandal toe. Why? Because there's a big gap that is present. Look at the great toe and look at the rest of the toes. Can you see a gap in between them? That is the sandal toe. So repeating, there is simian crease, there is single crease on the 5th digit, and there is a sandal toe. So these become your foot and hand abnormalities. These were all what a person is born with. But now I want to ask you that what are the complications that can happen in a Down syndrome person? Let's get going with that. So if I ask you the first question, do they have a risk of blood cancers? Yes. Leukemia, very, very important question. Listen to me very carefully. If they ask you which is the most common leukemia overall, overall means the age and everything is not given. They're just asking you overall, koi bhi age mein. So the way you write overall, na, I want all of you to mention overall. तो क्या लग रहा है? ALL. So the most common leukemia overall is ALL. But if they mention the age as less than 3 years, then your answer becomes AML M7. So if I say there is a baby of Downs, I don't know his age. 2 years, 5 years, 10 years, 12 years, I don't know anything. I just ask you what is the leukemia he is at a risk of. So when nothing is known, overall they have asked you, I will mark ALL. But if I say there is a 24-month-old baby, 18-month-old baby, basically anything less than 3 years of age, you will mark AML M7. Easy hai na? Let's move on further. What happens to their brain? Now tell me one thing, everyone knows what's Alzheimer's, memory loss, dementia, Alzheimer's. Which age group does that happen in? Alzheimer's happens at like 70, 75 years of age. But look at what is happening in these people. They are having premature Alzheimer's. Premature, pre-senile basically means that they will end up having Alzheimer's somewhere in their 30s. Right? So premature Alzheimer's is seen. Next, this is the most important question that I'm going to ask you. What is their cardiovascular abnormality? The most common cardiovascular abnormality is endocardial cushion defect. Many of the books mention ventricular septal defect. That is an old answer. So yes, ventricular septal defects are known, but those are like later on. The most common is going to be endocardial cushion defect, right? And in terms of GIT, there is one disease. There are lots of diseases, but there's one disease in pediatrics where they ask you a question, that is the megacolon, the Hirschsprung's disease or the megacolon that is associated with Down. So these are all the complications. Where do I expect a question? Either I ask you a question on leukemia with age, or I ask you CNS mein there is premature Alzheimer's, memory loss in their 30s, and cardiovascular, so very, very important. There is endocardial cushion defect. Now I want to tell you a little bit of gynae also over here. How are you going to do the testing? So you'll say, ma'am, the testing is number one done in the form of a screening. So screening kaun karta hai? Two people do the screening. One, a radiologist does the screening in the form of an ultrasound, and second, a pathologist does the screening. But this is screening. After that, later on, I will tell you one confirmatory test also. So screening mein, the radiologist sees two things. Number one, did I tell you the nasal bone will not be developed? So there is nasal bone hypoplasia. And secondly, the radiologist notices increased nuchal translucency. the radiologist notices increased nuchal translucency. So if these two things are noted by a radiologist, there is a very high suspicion of Downs, that is nasal bone not developed and nuchal translucency which is seen near the neck. So nuchal translucency increased, very high chance of Downs. So the radiologist will say, can you do some markers? There are lots of markers that can be done. There's a double test, a triple test, a quadruple test. So yes, as you go on, I will tell you about two main tests that are done. There is a triple test and there is a quadruple test. And what is this? These are nothing but blood tests. All that you need is simple a blood sample, mother ka blood sample. That's all that you need. So triple test has beta HCG, then it has alpha fetoprotein, it has estriol. And to all of this, if I add inhibin A, that becomes a quadruple test. How simple. Till the time three things were there, it was a triple test. If I add one more thing to it, it becomes a quadruple test. So you will ask me that when are you suspecting Downs? When are you gonna suspect Downs? When the beta HCG, repeating, when the beta HCG is high, alpha fetoprotein is low, estriol is low and inhibin is high, that is when I suspect Downs. How will you learn this? Dekho, whatever things that have H in it, high in it, dekho, inhibin has high in it. So when inhibin is high, I suspect Downs. Beta HCG has H in it. So when beta HCG is high, I suspect Downs. Look at the others. The others are simply low. You can see alpha fetoprotein is low, estriol is low. Ho gaya, easy to learn. All the HH things are high. HCG is high, inhibin is high, but alpha fetoprotein and estriol are low. When I see this kind of a profile, I start suspecting, question mark Downs. Why suspecting? Because these are screening tests. How am I going to do the confirmation? Confirmation is done by something called karyotyping, which I will be teaching you in a while, right? So karyotyping is what is going to give me the confirmatory analysis of this, right? Down syndrome, okay, clinical features, complications and testing. Shall I go on to the other trisomies? This was trisomy 21. Now I'm going to ask you, what is Pettau syndrome? Pettau syndrome is trisomy 13. Right, because we always learn that patane ka age is puberty ka age. Patane ka age, Pettau syndrome is puberty age, that is trisomy 13. And what is Edward? E for E. So Edward syndrome is going to be trisomy 18. Now before I go on to their features, there are some things which are common between them. If I ask you what are the three things which are common between Pettau and Edward, please note that firstly both these kids are gonna be mentally retarded. So mental retardation is coming everywhere. Downs mein bhi tha, Pettau mein bhi hai, and Edward is also gonna be there. Their cardiac abnormality is the same, patent ductus arteriosus. Repeat with me. What was the cardiac abnormality that you saw in Down syndrome? It was endocardial cushion defect. What is the cardiac abnormality over here? It is going to be a case of patent ductus arteriosus. And what do you see in their feet? You will see such convex feet like a rocking chair. All of you have seen that rocking chair. So they have something known as rocker bottom feet. Very, very important. So three things, PDA, MR and rocker bottom feet are seen in both of these kids. Now let's go on to their individual stuff. So you will realize that for Pettau syndrome, I have made three things. That is, I have made one extra finger over here. I have made some clefting over here. And I have made some keyhole kind of thing over here. So starting with it, firstly, remember the extra finger is, of course, everyone knows the very famous P for polydactyly. Then we know what is it in the cleft. You can see that in front of you. You have the famous cleft lip and cleft palate. And finally, what you see over here is something known as coloboma. It is coloboma. So they say in the eyes it looks like a keyhole. It is a keyhole defect. So you realize that this is only seen in Pettau. Mind it. This is only and only seen in Pettau syndrome. So P for Pettau, P for polydactyly, P for Pettau, P for palate and lip abnormalities. And finally you see something that is known as coloboma. What do you see specifically in Edward? In Edward, you will realize, look at the back of the skull, this part of the skull, this part occipital. So occipital region is very, very prominent and the chin is very, very small. So what is this going to result in? The radiologist sees a strawberry skull. What the radiologist is going to see is the very famous strawberry skull. Again, repeating, why strawberry skull? Because the back side of the head is very, very big and the chin is very, very small. So strawberry skull is seen. Other than that, look at their fingers. They have the very famous overlapping fingers. They have overlapping fingers, and rocker bottom feet, so I have anyway told you. Some of them can also have some problem in the kidney. Sometimes a horseshoe kidney is also noted. A horseshoe kidney like that can also be seen. These are other developmental abnormalities noted. But remember that strawberry skull and rocker bottom feet with overlapping fingers, very, very important. These were to do with the two, Petau and Edward. Shall we move forward? I'm only talking about numbers. What is it about X and Y chromosome being extra? So remember, what is Klinefelter? Klinefelter is any man. Any man is what? Any man means 46XY. Every man is 46XY. But I'm saying that now this man will have an extra X chromosome. So that means normally if a man was 46XY, I am saying there is an extra X chromosome that is going to add to extra X hoga. The total will also change. It will now become 47XXY. If I would have added 2 X chromosomes, I would have made it 48XXXY. So basically, as many extras you will add, don't forget to change the total number also. That's a very common mistake students do. They only keep adding XXX and they forget to add the total number, and that's why the examiner will catch you in the options. So if they say Klinefelter is 46XXY or is it 47XXY? So you will say XXY, so I know both of these are looking like Klinefelter, but this is wrong. I have to change the total number also, na? So it becomes 47XXY. Samajh aa gaya? Where the examiner is going to catch you? Is going to catch you in basic mathematics. Okay, so Klinefelter means it's primarily a male, means secondary sexual characteristics will be of a male. The gonads will also be the testes, everything of a male. But problem hai that there is extra X chromosomes. Please note, more the number of X chromosomes, more the number of X chromosomes, more is going to be the mental retardation. Because of extra X chromosomes, there is a disarray that is created. So remember, more the X chromosomes, more is the mental retardation. Now they will ask you that, theek hai to male, matlab everything is of a male, but is it like well developed? Because so many X chromosomes are there, so it is not well developed, na? You will say the secondary sexual characteristics will not be well developed. The testes will also not be well developed. So these patients will have hypogonadism. The secondary sexual characteristics will not be well developed. But one thing, please remember, they are very, very tall individuals. They are very, very tall individuals. Some 6.5, 7 feet kind of individuals are Klinefelter wala. There are 2 questions or 3 questions, I would say, which are very, very famous. Question number 1 that they ask you is that what is the cardiac abnormality that you see in these patients, and that is mitral valve prolapse. Is there any other disease in pathology where I have taught you in genetics only a very, very tall person with mitral valve prolapse? Socho, a very, very tall 9 feet person with mitral valve prolapse was also Marfan's, na? Marfan's is also tall with mitral valve prolapse. Same over here, tall with mitral valve prolapse. Question number 2 is what they'll ask you is, what is going to be the most common cancer that can occur in these patients? So remember, the most common cancer, because male hai na, male breast cancer is very commonly seen. Male breast cancer. Question number 3, is this associated with any autoimmune disorder? Yes, this has been associated with SLE. Very important. This is associated with SLE. So ye sara to all pathology related questions. They will also ask you one hormone physiology wala question, which I want to put as a box over here, because if you ask me which is the one most expected question, ma'am, of this chapter that you have seen in your PYQs, I'll say wo ye hai. That is, what is the hormone profile? So please note, the hormone profile of Klinefelter hoga to testosterone, because it's a male. But tell me, the male is not well developed. Male ka problem ho raha hai na, there are extra X chromosomes. So ultimately the testosterone levels shall fall down. And as a feedback, what will increase? Tell me. As a feedback, FSH and LH shall increase. Simple. So what is the hormone profile? The testosterone levels will be low, and as a feedback, the LH-FSH is going to be high. That is what you have for Klinefelter. That's the best possible one slide for Klinefelter that we can make. Tall individual with mitral valve prolapse, at a risk of male breast cancer, autoimmune disorder is SLE, and the hormone profile is low testosterone with high LH and FSH. Let's move on to the last one, and that is Turner's syndrome. We have all the things in front of us. We are going to quickly look at Turner's, but tell me, till now I was talking about extra 21, extra 13, extra 18 and so on. Finally, I'm talking about monosomy. I'm talking about monosomy. And that is monosomy X, means these patients are 45X0. They have only one X chromosome. When तो है तो female, but there's only one X chromosome. This means there is gonna be a problem in the ovaries. There are rudimentary ovaries. Guys, please note, there are rudimentary or streak ovaries. दोनों words use होते हैं, rudimentary or streak ovaries, which basically means menstruation shall not occur. These individuals are gonna have primary amenorrhea. They will never ever commence menarche. There is never going to be any menarche. There is never going to be any menstruation because they are not having proper ovaries. And why is there no proper ovary development? Because one of the X chromosomes has gone missing. That is the most striking thing in gynecology that you will see. But other than that, they tend to have a short stature. They are usually short. And their neck, there's a lot of focus in these people on their neck. So you will see there's a skin, like from the neck to the shoulder, na, a connecting skin hota, which you can pull out. So what is that connecting skin that you have? That fold of skin is known as the webbing of the neck. That is one thing that you have. Number one, you see webbing of the neck. Another thing that you see in the neck is a tumor. That tumor is cystic hygroma. That is the only question of cystic hygroma that you get in path, medicine, surgery, pediatrics, everywhere. The only question of cystic hygroma. So listen to me like super confidence ke saath, alert hoke, because that's the only question possible. So what is a cystic hygroma? Cystic hygroma is nothing but a lymphangioma in the neck. When the lymphangioma occurs in the neck, and that is a cystic hygroma, so they ask you which is the only chromosomal abnormality in which cystic hygroma can be associated. So the neck, so turn the neck, that is what I'm going to say. Turners may turn the neck. What is happening in the neck? Cystic hygroma is happening in the neck, and that is lymphangioma. What else can you see, guys? Obviously, everywhere I have done a cardiac problem. So here also I will have to do a cardiac problem. And over here, it is going to be the bicuspid aortic valve. Over here, it shall be the bicuspid aortic valve. So before I end the story of Turner's, I just want to tell you some common points up till now that we've done. I told you that in everywhere there was mental retardation. Downs, Pettau, Edward, Klinefelter. This is the only place where IQ is usually normal. Usually normal means Turner's mate is usually IQ is normal of the patient. That is one summary I wanted to tell you. Everywhere mental retardation, in Turner's it is normal. Second, I asked you a heart problem for everything. So can you revise with me? For Down syndrome, can you tell me what was the heart problem that we studied? So for Down syndrome, it was endocardial cushion defect, which was the most common. What was it for Pettau and Edward? For Pettau and Edward, it was coming out to be patent ductus arteriosus. What is it for Klinefelter? For Klinefelter, I told you it's a tall person with mitral valve prolapse. And what is it for Turner's? For Turner's, I said bicuspid aortic valve is the most common. After that, I agree, you must have written or read about coarctation of aorta. That is also there, but bicuspid aortic valve is the most common thing that you are going to see over here. I hope everyone's okay with Turner's. Numerical problems done, because now I'm going to start off rapidly and talk about what are the different genetic diagnostic modalities. If you go back to the main syllabus, we've spent a considerable 1 hour on this because that is like detailed. Now in the rapid review, I'm going to focus on certain important things like karyotyping, PCR, CGH. These are the 3 things. If you have extra time to revise, please ek baar go back to the main course and do the pedigree analysis also. If you want, like, if just in case there are students who might only be referring to this syllabus and have not got the time or have an exam coming up, so you've not been able to listen to my full course. So agar kuch extra karna hai over and above this, then go to the full course and just listen to the pedigree, which I'm not covering over here. But yeah, all the other things I'm putting up in the rapid review. So now let's start. What all did I tell you? You have to do karyotyping, FISH, PCR and CGH. We're going to spend 20 minutes and in a beautiful manner, we're going to finish it. And I can guarantee you're going to love it at the end of it. I know you're scared of it, but I guarantee you'll get a beautiful result at the end of this. Rapid review only is more than enough. So when I talk about karyotyping, you know, karyotyping is nothing but the study of the chromosomes, right? Karyotyping is defined as study of the chromosomes. So tell me, what is the sample that you're going to take? Now you will say, ma'am, that depends. If I'm dealing with somewhat like a pregnant lady, my possibilities are that I can take an amniotic fluid sample, that is amniocentesis. But even before an amniotic fluid sample, what is earlier diagnosis that you study? Chorionic villus sampling. Na? So even before, or if you want to do an even earlier diagnosis around the 8th week, you can even do chorionic villus sampling. That is if you're dealing with a pregnant lady. Second scenario, what if you're dealing with a child or an adult, basically a person who's out of the womb, a child or an adult, then in that the best sample is that you take just a simple 2 ml of blood le lo. Nothing very fancy. You can take 2 ml of blood, and in that blood sample, this is the question: what is the cell that you are interested in? I am interested in a lymphocyte. Very important. Where do you do the testing? We are going to do the testing on a lymphocyte. Again, repeat it with me thrice. On what do you do karyotyping? Lymphocyte, lymphocyte, lymphocyte. Okay? So now the first step is you are going to arrest the cells. Where are you going to arrest the cells? The arrest is going to happen at metaphase. Again, every word is such an important PYQ. Matlab, I'm not writing PYQ everywhere. Slide ke starting mein I will write PYQ because every word in this slide is a PYQ. Okay? So where are you going to arrest the cells? At metaphase. How will you arrest it? You will use a chemical called colchicine. Coming to the next, fixative. What fixative do we use? We use the famous Carnoy fixative. We use the very, very famous Carnoy fixative, and please note that the Carnoy fixative has two things. It has methanol and it has glacial acetic acid. It has methanol and glacial acetic acid in how much of ratio? So dekho, Carnoy, CA. C is what? The third alphabet. And A is what? The first alphabet. So what shall be the ratio of Carnoy fixative? C and A, 3 and 1, 3:1. How easy. Finally, what is the staining? We can do staining on two microscopes. Either I can use the fancy wala fluorescent microscope, or I can use the very, very basic light microscope. So light microscope के लिए what we do is G staining or G banding. G मतलब GIMSA. The most common staining or banding that we do is going to be GIMSA banding. I'll show you a picture. Have a look at this. Can you see why this is a normal karyotype? Why did I call it banding? Because you can very well see there are dark and light bands that are present. So we know that yeah, this is known as banding. This सबसे common वाला banding है. And how are they arranged? You can see the first chromosome is so big, and as you are coming forward, the other chromosomes are becoming chota, they're becoming small. So basically, they are arranged in the decreasing order of length. So obviously they will ask you, which is the shortest chromosome? No, it's not the last one. Somewhere in between you get your shortest chromosome. So please remember, the shortest chromosome is that 21 Downs wala chromosome. 21st chromosome is the shortest chromosome that all of us have. And what is this technique? ये क्या है? G banding, normal light microscope. So remember, G banding के लिए गरीब वाला microscope. G for गरीब वाला microscope मतलब usual वाला light microscope. Whereas when we do something called Q banding. What is Q banding? Q banding means I have added a stain called quinacrine. Quinacrine is not sounding garib. Quinacrine is sounding like a queen. And for the queen, I will need something fancy. That fancy stuff is known as fluorescent microscope. So if I now show you a picture like this, which is of Q banding, you can very well see that yeah, this is definitely a case of fluorescent microscopic examination. And this is also arranged from largest to smallest as we are going. Samajh aa gaya everyone? So if you have a garib, although light microscope is not garib, it's also damn expensive if you go to buy it. But yeah, in general telling you, if the usual wala na, so we consider it garib. That G banding is for the garib microscope, that is light microscopy. And Q banding is queen. Queen needs something fancy. So fluorescent microscope. So karyotyping done. What are the questions? Arrest at metaphase by which chemical? Colchicine. What is the fixative? Carnoy fixative. What is the ratio? Ca, 3:1. Which banding is most common done on light microscope? G banding. Which banding is done on fluorescent microscope? Q banding. Can you give one analysis quickly? Iska diagnosis batao. You will say, ma'am, everywhere 1 2 1 2. Every chromosome is in pairs na, तो जब तक 1 2 1 2 count हो रहा है, okay. This is chromosome 1 1 2, chromosome 2 1 2, 3 1 2. 1 2. Everywhere I keep doing 1 2 1 2, and suddenly when I come to this chromosome 21, I say it is not 1 2, it is 1 2 3. This means this is a case of trisomy 21. This means this is a case of Down's syndrome. Everyone's understood this concept? Yes? This was about karyotyping. Now you can, instead of this, examiner will give you a chromosome here, you will say, oh, trisomy 18. Edwards syndrome. Examiner will give you an extra chromosome over here, you will say, oh, trisomy 13. Pettau syndrome. So now we can do any diagnosis on a chromosomal analysis. We are very confident. So our first technique seems to be totally sorted. Now I move on to the second technique, and that is FISH. What are the 2-3 main questions on FISH that I'm going to get? So firstly, you have to know the full form. It is a fluorescent technique. So fluorescent in situ hybridization, repeating, fluorescent in situ hybridization, and here the cells that you use are the cells in interphase. So please remember, karyotyping में metaphase था and fish में क्या होता है? Fish में it's gonna be, I have learned it as fluorescent interphase hybridization, because that gives me a rule that okay, fluorescent in situ hybridization को I have learned it as interphase hybridization. ठीक है, तो interphase में cells are used. After this, this color coding will be given by the examiner. You are not supposed to learn this color coding. What is green, what is red, he will tell you. So he has told you that green is 13. Okay, this is 13, this is 13. 1 2 1 2 jab tak hai 2 2 are there, I'm good. Then the examiner says red one is 21. I can see how many 21s? I can see 3 21s. What is your diagnosis? This is also a case of trisomy 21. This is also for Down's syndrome. Has everyone understood how fish analysis is done? Very simple. So not only this, what if there was any fusion? So for example, now let me give you another example. Now, instead of calling it 13 and 21, examiner said that one chromosome was 9 and one chromosome was 22. So you saw that okay, this is 9 and this is 22, alag hai. But what if I would have seen them fused with each other? What would you have called it? Translocation 922. So you know, basic concept is that I can use this technique for any kind of chromosomal abnormalities. Any kind of chromosomal abnormality that I want to see, whether I want to see number problem or translocation, fusion problem, kuch bhi dekhna, any chromosomal thing I can do fish. And for fish, the technique, the phase that I will use it in is interphase. So fish is also done. Second technique, tick mark. What is the third technique? We have to do PCR. PCR was a recent question in FMG, NEET and INI CET. So every exam pattern is following PCR. The first question that came is polymerase chain reaction ka steps kya hota hai? So remember, DAE. DAE. So what is DAE? The first step is referred to as denaturation. Denaturation means that look at this DNA of yours. Normally everyone has a double stranded DNA, na? So denaturation means alag alag. You are going to separate it into single strands, and that is done at 94 degrees centigrade. So double stranded is converted into single stranded. After that, what is the next step? You are going to attach something. That is going to be annealing, and annealing is done at 54 degrees centigrade. So what is annealing? I will attach one primer over here. I will attach one primer over here. Basically पहले double से single करा, and then single को अब दोबारा double करना है. So both of these you have to convert individually into double. So this one will be converted into a double, this one will be converted into a double. दोनों को double करना है, right? So you have to bind something, that is annealing, and then you'll extend it. So the last step that you have is going to be extension, and that extension is going to be done at 72 degrees centigrade. So you have finally extended this, made this into double stranded. You have extended this and made this into double stranded. So have you converted one double stranded DNA into two copies eventually? है ना? That is what you're doing, from 1 to 2, 2 to 4. Then again you will do the cycle 2 to 4. Then again the cycle 4 to 8, 8 to 16, 16 to 32. That is what is a chain reaction. Na? From 1 to 2, 2 to 4, you are increasing. So how are you increasing? This step, this process has to be mucked up. Do not mess up on this. DAE, denaturation, annealing and extension. 94 degree, 54 degree, 72 degree. Very, very important that you have. But this was just a general PCR. There are lots of PCRs that you have to know in the exam. What are the types of PCR? So please note, Sanger sequencing has the G in it. So that is going to be the gold standard PCR. That shall be the gold standard PCR. What I'm telling you, DAE and all, gold standard PCR. Just remember, you will say, acha ma'am, I did this process, DAE, bar kara, 1 to 2, 2 to 4, 4 to 8. I got hundreds of copies, but ultimately I had to stop also. Na? So how are you going to stop it? You are going to stop it by using DDNTPs. What is DDNTP? Dideoxynucleotide proteins. Dideoxynucleotide proteins. So please remember, this is important not for FMG, but for NEET and INI, it is important that when you have to stop the PCR, you are going to stop it by DDNTP, dideoxynucleotide proteins. And this is what we call as Sanger sequencing. So please note, Sanger sequencing has a G, so that is going to be the gold standard PCR. Next, we come to SBPE. What is SBPE? Single base primer extension wala PCR. Single base. I have a known locus. I know what to focus on in the body. So, for example, examiner says, I am suspecting hairy cell leukemia. So, I know, acha, you're suspecting hairy cell leukemia. I know all cases of hairy cell leukemia have one mutation called BRAF V600E mutation. All cases of hairy cell leukemia have that. That means that 600 codon pe jaake target karo. Now, for example, I tell you, this is a question that is going to come in your exam tomorrow. Or what do you have to do? Do you have to sit and study 1000 questions after that? No, you will say, I will only study this one question and go. I have the known question, the known locus, then why should I focus on anything else? Exactly what I'm doing. When you have the exact known locus, what do you do? Which PCR? Single base primer extension. But when everything is unknown, when you have a totally unknown locus, anything, I say, I don't know what is going to come in tomorrow's exam. I have no idea what is going to come in tomorrow's exam. Then you say, ma'am, in that situation, I am going to study everything. So, kya karoge? RFLP, restriction fragment length polymorphism. Let me give you an example. I say that, I don't know, in this family, autosomal dominant disorder is going on, autosomal recessive disorder is going on. I have no idea what is going on in this family. So, you will have to now find out. Here is the father, here is the mother, here is the child. Ab dhundo. Take up everyone's genetics and find out what is going on in their family. So, then what will you do? When there is a totally unknown locus, for a totally unknown locus, you're going to do RFLP. Let's move on to the next. In case you're dealing with a low tumor yield or sometimes known as a contaminated sample. Sometimes known as a contaminated sample. So low tumor yield means what? It means that if you come to me and say, ma'am, this is a breast biopsy. I want to find out, why does she have breast cancer? Can you tell me what genetics? Why does she have breast cancer? I say, breast cancer can have 1 million things. So I will have to do everything, all sorts of genetic analysis I will have to do. You say, हाँ ma'am, do it. But एक problem है. I am first year intern or first year resident, ma'am, and my technique of doing breast biopsy was not so good. So here is the sample of breast biopsy, but cancer cells are only 10%. What did you say? The cancer cells are 10%. It is a low tumor yield. When I say low tumor yield, which kind of PCR am I going to do? I am going to do a pyrosequencing. Okay? Next, if you have lengthy DNA, think of one condition you have studied. Where do we have lengthy DNA? Lengthy DNA, for example, CGG. कौन सा disease था in which CGG was going on? Fragile X syndrome. Tell me any other. CTG. DNA becomes very, very lengthy. In a very, very lengthy situation, you will do lengthy wala PCR. You will do amplicon length analysis. Next, what were you doing for COVID? COVID के लिए क्या किया था? You will say, ma'am, oh, COVID, तो how can I forget? Most traumatic time in our lives. We did RT-PCR. No, you did RRT-PCR. In COVID, you did RT-PCR. You did a combo PCR, means you did real-time and reverse transcriptase PCR. So please remember, for COVID, basically reverse transcriptase is done for any other RNA virus. Na? COVID ke liye you did RRT-PCR, real-time reverse transcriptase PCR. So reverse transcriptase kyun kara? This to you know na. Whenever I'm dealing with any RNA virus, I am going to do a reverse transcriptase. But why did I say real-time? Real-time is a quantitative PCR. It not only tells me that हाँ virus है, it also tells me kitna virus hai. It also not only does it tell me virus is there or not, it tells me how much, quantity, load. So whenever they will ask you, acha, it's a case of some leukemia, how many genetic copies are there? When that how many comes, na, how many viruses are there? How many genetic copies are there? How many copies of Philadelphia chromosome are there? When that how many wala question comes, you say, oh, they're asking me quantity, I will use quantitative PCR. Quantitative PCR is RT, real-time PCR. So now I think I've understood that for COVID, I was doing a combo. Combo means I was doing RT-PCR. The last one, when I have to go in for some research work or I have to do some population study. Like you want to find out in a population which blood group was more susceptible to COVID, or you want to find out which gene problem is more susceptible to diabetes. You want to do some population study all over the world. You will do some wide study, genome wide association study. ये world wide वाला study है, ठीक है? That is how you will learn it. Genome wide association study, world wide वाला studies. You want to do diabetes, hypertension, blood groups, everywhere in the world you want to find out and become like some Nobel Prize winner. So you're going to do genome wide association study. So jaldi se, without looking at it, without any cheating, quick revision. If I ask you what is Sanger, Sanger is going to be the gold standard. Single base primer extension when the locus is known, RFLP when the locus is not known, pyrosequencing when there's a very low tumor yield, genome wide association study when worldwide research studies karna hai. What is amplicon length analysis, lengthy DNA like Fragile X syndrome. RRT PCR is done for COVID. Real time basically means quantitative. It tells me how much of something is being done, and these are your types of PCR which you can tick mark. The last part of this rapid review is coming down to the last technique, and that shall be CGH. So CGH reminds me of a red light. It's very simple. So now let's start with the last technique, and that is CGH. So first you guys need to know what is the full form of CGH. CGH stands for comparative genomic hybridization. So can you see this word? I'm comparing something. What am I comparing? I am going to compare the patient with a normal person. तो देखो, normal person को let us give a green color. A green color will tell me normal है, everything is fine. But alert color, I have given the alert red color to the patient. So patient's genetics I have given alert red color, and normal person I have given a green color. Now what am I going to do? I am going to combine the red and the green. Red and green hybridize. That is why we call it hybridization. Comparative genomic hybridization is what it's called. So now when you combine, if you get, this is red, this is green, if I get equal to yellow. If I get equal, this means there is no defect, it is totally normal. Normal matlab red and green, patient and normal, ये दोनों same है. So this means patient doesn't have any problem, सब कुछ normal है. If you get more of this red color, means patient has something more. That is, I'm getting more of red color. This means this is a case of gain of function mutation. It is a gain of function mutation that has happened. And if I get less of red color, patient ka color kam hai, patient ka color is less, red is less, this means green is gonna be more. ग्रीन क्यों ज्यादा है? सी नॉर्मल पर्सन हैज द सेम अमाउंट ऑफ जीन्स ना, नॉर्मल पर्सन तो ग्रीन ही रहेगा. सडनली द रेड कलर हैज गॉन डाउन. व्हाई हैज द रेड कलर गॉन डाउन? पेशेंट हैज समथिंग नोन एज लॉस ऑफ फंक्शन. देयर इज लॉस ऑफ सम जेनेटिक प्रॉब्लम दैट इट हैज. सो ऑलवेज रिमेंबर इट लाइक अ रेड लाइट, दैट इज रेड येलो ग्रीन. रेड येलो ग्रीन मतलब रेड इज ऊपर ना, रेड येलो ग्रीन रेड लाइट वाला सीन यू विल रिमेंबर. सो रेड इज ऑब्वियसली ऊपर इन अ रेड लाइट, सो यू विल से दैट मैम रेड इज समथिंग इंडिकेटिंग गेन. Green is always niche, so that is meaning loss, and yellow is in the middle, so that means it is normal. So remember, the top wala is gain, the bottom wala is loss, and the central wala is normal. So if I ask you, what is this? You'll say, oh, red is at the top. This is a gain of function problem. What is this? Green is at the bottom of the red light. This is a loss of function problem. What is this? Yellow to matlab normal. Yellow is normal, and that is how we can do CGH, comparative genomic hybridization. Do you want to practice some quick questions? Question number 1. Karyotyping done using fluorescent microscope is with which of the following techniques? Guys, when I say fluorescent microscopy, तो fluorescent microscopy में do I need G banding? No, fancy. Queen के लिए something fancy. So which banding are we going to do? We will be doing the Q banding. Let's pick up one more question. There's a 54-year-old female who's presented with a breast lump measuring 9 by 7 centimeters in the upper outer quadrant. The lump is firm to hard in consistency and seems to be fixed to the underlying muscle. The TrueCut biopsy reveals, oh, cancer is there, infiltrating ductal cancer, and you are taking it up for genetic studies. However, the number of the tumor cells are only 8% of the biopsy. I am dealing with a low tumor yield. The rest of it is some fat and ducts. Tumor yield is low. What is the type of PCR that I will do for a low tumor yield? We would be going ahead with the very famous pyrosequencing. You know this, everyone's feeling confident because you've done these kind of questions right now when I taught you PCR. Well, with that, we wrap up our rapid review of genetics. So now let's begin with the review of the next chapter, and that is neoplasia, a chapter which is not liked by many of the students, but definitely something which gets you a lot of questions in the exam. So let's get going. Means it's a chapter which is going to do with a lot of tumors, right? Tumors and growths are going to be present in this chapter. So first and foremost, I'll start with classification of neoplasm. So neoplasia classifications is what we are going to begin with. And we know that we classify tumors into 4 categories: benign, malignant, teratoma, and mixed. Whenever I use the word benign tumor, I have to put something like oma in front of it, like lipoma, fibroma, adenoma. Oma will always be in benign. However, there are certain exceptions to this rule. And what are the exceptions? Means if, for example, they say lymphoma. Lymphoma is oma but is not benign. Similarly, they write melanoma. Melanoma is oma but not benign. Same way, seminoma. Seminoma is again oma but not benign. We have something called chloroma. Please note, chloroma is something which I will talk about when we go to hematology. Chloroma is nothing but AML in the soft tissue. Chloroma is nothing but AML in the soft tissue. Which soft AML kya hai? AML is acute myeloid leukemia. It's a blood cancer. Blood cancer should happen in blood. This is not happening in blood. This is a blood cancer that is happening in the soft tissue. And which soft tissue are we talking about? Most commonly, this occurs in the orbit. So please remember, benign tumors, that is oma, except for lymphoma, melanoma, seminoma, chloroma, and AML in soft tissue, that is what chloroma is. So all of them have oma, but they are not benign. They will actually come under malignant tumors. Got it? The next variety is malignant tumors. And please note, malignant tumors are of 2 types: carcinomas and sarcomas. ये दोनों cancers हैं. When I say cancer ना, it could be a carcinoma, it could be a sarcoma. So anything that is going to have an epithelial origin, anything that is arising from the epithelial or epithelial origin is going to be a carcinoma, and anything that is going to have a mesenchymal origin is going to fall under the variety of sarcoma. So let me give you an example. When I say there is a cancer of squamous epithelium, epithelium है ना, so I will use the word carcinoma, squamous cell carcinoma. Or I say transitional epithelium, so transitional cell carcinoma. Whereas if I say lipid is mesenchymal tissue matlab sarcoma, so liposarcoma. If I say bone is also mesenchymal tissue, bone matlab osteosarcoma, cartilage matlab chondrosarcoma. So wherever I use mesenchymal tissues, I will use the word sarcoma. Wherever I use epithelial tissues, I will use the word carcinoma. Sounds well? Now I come to the third category, and that is known as a teratoma. When I talk about a teratoma, I think this is one picture that comes to everyone's mind. When I'm talking about a teratoma, please note that teratoma has the word oma, and everyone believes कि हाँ, oma matlab it must be benign. But I have told you na, exceptions are always there. So please note, what is a teratoma? Teratoma is a tumor which is arising from how many germ layers? Minimum 2 or more than 2 germ layers. Teratoma is a tumor that is arising from 2 or more than 2 germ layers, and please note that this teratoma can be of 2 types. One is known as a mature teratoma and the other is known as an immature teratoma. There's a mature teratoma and there is an immature teratoma, because now the twist in the story is going to come. When I say mature teratoma, that is what we are referring to as the benign tumor. The benign one is the mature one, whereas which is the one which can be malignant? The one which can be malignant is going to be an immature teratoma. Very important. So what do I say? When you say teratoma, you'll say, ma'am, I can't say anything. I cannot say कि ये benign है या malignant है. So you will say that you tell me which kind of teratoma are you referring to. If you're referring to a mature teratoma, that is benign, and if you're referring to immature teratoma, that might be malignant. What is the picture that you're seeing over here? I'll tell you the organ. This is actually the ovary, guys, and in the ovary, can you see this tuft of hair? So basically, teratoma always looks like that. Hair, bone, teeth, skin, so many of these things are present. That is what happens in a teratoma. And please note, this also has a cyst present. So whenever I will see something called a benign cystic teratoma, Whenever I will see something called a benign cystic teratoma, for that matter, rather than calling it benign, can I now call it mature? Because benign and mature means the same, na? So mature cystic teratoma, this is known as a dermoid cyst. So many of you use dermoid cyst word so easily, casually. Today you know what is a dermoid cyst. Dermoid cyst is a teratoma. कौन सा वाला teratoma? Mature, benign wala teratoma it is. And what does it have additionally? It has a cavity, it has a cyst in it. So mature cystic teratoma is a dermoid cyst. Easy with everyone? Coming back, teratomas are sorted. Now I come to the last one, that is mixed tumors, and I'll give you the best example for a mixed tumor. You might have studied something called benign mixed tumors in surgery. I'll give you a hint. Salivary gland chapter. Kuch yaad aaya? Anything that you can learn? Benign mixed teratoma in surgery? Salivary, parotid, kya yaad aaya? So please note, pleomorphic adenoma. Pleomorphic adenoma is also known as the benign mixed tumor. So you will ask me, what is the meaning of mixture? What is getting mixed? It has both epithelial and mesenchymal components in the same tumor. Epithelial and mesenchymal components both are present, and that is a benign mixed tumor. I hope everyone's okay with the classification. Benign, malignant, teratoma and mixed tumor. Mixed tumor ka example, salivary gland, parotid, pleomorphic adenoma. The next thing that I go on to, classification ho gaya, but there are two terms that require my attention. What is a hamartoma and what is a choristoma? First and foremost, hamartoma has everything hamara. I'll remind you of your mnemonic once again. Hamara means everything is my own. Hamara tissue, hamara money, so my money, and if I pay, then I get to eat the popcorn. The basic hostel life rule. If I am going for watching a movie and if I am paying for the popcorn, then I get to eat the popcorn. So it is hamara tissue, hamara paisa, hamara popcorn. Hamara tissue, my tissue, my money, my popcorn. That means when I'm talking about hamartoma, the most common example that I study of is a pulmonary hamartoma. The most common example of hamartoma is pulmonary hamartoma. It is oma means, of course, it is a benign tumor. It is a benign tumor undoubtedly, and I can see that what kind of tissue will it have? Will it have some ectopic tissue, like I'm saying pulmonary? So pulmonary matlab, will it have some tissue from the stomach or the pancreas? No, it will have hamara tissue, it will have pulmonary tissue. It will have pulmonary tissue, native tissue. Example of pulmonary tissue, cartilage. Isn't cartilage present in the lungs? Yes. So imagine this is having too much of cartilage. So there you see hamara tissue. And what does it show radiologically? It shows you the very famous Coin lesion. Pulmonary hamartoma radiologically shows you Coin lesion. And which calcification does it show you? It shows you popcorn calcification. Remember, on radiology you see Coin lesion, popcorn calcification, and pathology you see the very, very famous cartilage, hamara tissue. So that is why I said hamara tissue, hamara coins, and hamara popcorn. That is hamartoma. This is a previous year question. It is a benign tumor because oma hai. Now coming to choristoma. Choristoma also has an oma, but choristoma is an exception. It is not a tumor. Choristoma is chori ka tissue. Chori ka tissue means ectopic tissue. So for example, suddenly you say that in the stomach you are seeing pancreas. If there is pancreatic tissue which is present in the stomach wall, you are going to call it a choristoma. So please note, please remember this, that hamartoma is hamara own tissue and choristoma is chori ka tissue, that is ectopic tissue. Some other tissue has come and sat over there. Easy to learn, classification ho gaya. Now we move on to next, and that is the features of the neoplasia, what every cancer is going to have. So if they ask you, what is the hallmark of malignancy? The hallmark of malignancy is anaplasia. So now I want to explain to you what is anaplasia, hota kya hai, and there are two things that I want to differentiate. Before I move on to the rest of the features, I want to ask all of you that what is the difference between dysplasia and anaplasia? Because please note, dysplasia is said to be pre-cancer and anaplasia is said to be cancer. If I had to explain it to you like a bilkul layman, na, matlab non-medical information I had to give you, I would have said dysplasia is pre-cancer, anaplasia is cancer. And anaplasia has a definition. That definition is what you have to lagao ratta, that is loss of differentiation. Definition is loss of differentiation, and that is what you see in a case of anaplasia. So let me explain. One is, you'll say, ma'am, if you give the diagnosis of pre-cancer to the patient versus the diagnosis of of cancer to the patient, his world is only going to change. His treatment will change, his surgeries will change, his chemoradiotherapies will change. So it makes a hell lot of difference of what diagnosis I'm giving, whether I'm giving dysplasia, whether I'm giving anaplasia. But how do I decide? Because all that pressure now, guys, is on me. I am the pathologist, all that pressure is on me to give the diagnosis, pre-cancer versus cancer. I just go with a calm and composed mind. I go and look at the basement membrane. If the basement membrane is intact, this means I am still in that pre-cancer stage. But if the basement membrane is broken like this means now the cells are going to spread. Now the cells will go everywhere. Now cancer is going to happen. So remember, if the basement membrane is intact, the person is still in a phase of pre-cancer. If the basement membrane is intact, but if the basement membrane is broken, so for example, if this, for example, is the basement membrane, okay, if this is the basement membrane, till the time it is there, pre-cancer, matlab all the cells are above it, it is there pre-cancer. But as soon as I remove this basement membrane, now all the cancer cells will go everywhere, matlab cancer has occurred. So remember, basement membrane is there pre-cancer, basement membrane is not there, is going to be cancer. Okay, now moving forward and coming back. So now you understand anaplasia is what? It is the hallmark, because there is going to be a basement membrane breach that you will be noticing over here. Now coming to the next feature, this was feature number 1. What is feature number 2? Feature number 2 is rate of growth. Common sense. If I tell you versus a benign tumor and a malignant tumor, which will have a faster rate of growth, of course you will say cancers are going to grow faster. Ye to you don't need to write also. This is common sense. Na? Just learn it. Rate of growth is one feature. The third and the fourth features are very important. Cancer spreading in the local vicinity and cancer spreading to distant places. So please remember, like for example, if your class test would finish or your ward leaving exam or some semester exam will finish, you will go to the market, okay, now my exams are finished. Local neighborhood you will roam around because you feel that my exams are finished, I should roam around. But then when your NEET PG or FMG, your main exam of life will finish, then you will, or what are you planning to do? That Goa trip with friends, everyone plans, na? Then you're planning that I will visit some distant place. Same way, when the cancer keeps roaming around in his local market, you call it local invasion. When the cancer says I want to roam around, go to the brain, go to the bone, go to distant places, so distant spread is referred to as metastasis. Okay? So now you will say that which of them is more reliable. Remember, the most reliable sign of cancer, the most reliable sign of malignancy is going to be metastasis, most reliable sign. And then they ask you what is the second most reliable sign. So the second most reliable sign of malignancy is going to be local invasion. So they ask you one thing, okay, reliable sign matlab every cancer is going to metastasize, hai na? Of course, you will say, of course, all cancers metastasize. But now comes a trick question. All cancers will show metastasis. All cancers show Mets matlab metastasis, but there is nothing all in medicine ever. There will be an exception, except two cancers, B and B, basal cell carcinoma and brain tumors. Brain tumors basically means gliomas. They do not show spread. Means what? All cancers will go, everyone wants to go to Goa, na? Wants to go to a distant place. All cancers will go to the brain, will go to the lungs, will go to the bone. But basal cell carcinoma kahan hota hai? Basal cell carcinoma occurs on the face, medial canthus. It keeps growing here only. It doesn't want to go to Goa. Same way, brain tumors of course they occur here, but they keep roaming around, they keep spreading here. Brain tumor will never come to the lungs, or brain tumor will never go to the bones. Brain tumor will keep growing here. So all cancers spread and they want to go to Goa, except basal cell carcinoma and brain tumor, which is like, this is all Moo Maya and I don't want to go to Goa. I am happy roaming around in my local neighborhood. They only and only show local invasion. They don't show metastasis. They only and only show local invasion. I hope you've understood who are the two people who are above Moo Maya and they don't want to go to Goa and to distant places. B and B, basal cell carcinoma and brain tumor, that is gliomas. They don't want to go to distant places. They want to roam around in their local neighborhood. Okay? Chalo, on that note now, but I want to, everyone I know, your mind is stuck on how to go to Goa, how to reach Goa. What are the different methods of spreading? What are the different methods of metastasis? So please please note, these are all the pathways of metastasis. There are 4 pathways of metastasis, or 4 routes by which I can send you to Goa. Road travel, air travel, train travel. So like that, I'm going to send you to Goa one by one. So what is the pathway? And ultimately, I'll tell you there is no pathway, because Goa is just an imaginary plan which is never ever fulfilled till a very great time in life. Okay, so what is the pathway of spread? So remember, all carcinomas are going to spread via which method? They are going to go into the lymphatic channels. All carcinomas go to lymphatic channels, and all sarcomas are going to go into the blood vessels. And when I say blood vessels, guys, which blood vessel? Vein is more common or artery is more common? Vein is more commonly involved than arteries. Vein is more commonly involved than arteries, because veins are patla, na, thin walled. It's easy to go through a thin wall. So veins are more commonly affected than arteries. So remember, all carcinomas go to lymphatic channels and all sarcomas go to hematogenous, but all to kuch hota nahi. There is nothing all in medicine. Means there is going to be an exception. So except RCC, HCC and follicular carcinoma thyroid. Except RCC, HCC and follicular CA thyroid, these are not going to go into the lymphatic channels. A cross connection hoga. Where will they go? They will go into the hematogenous. They are going to go into the blood vessels. Similarly, I studied all sarcomas are going to go. So I'll repeat this once again. Pehle, what did I say? All carcinomas go where? They go into lymphatics, except RCC, HCC and follicular carcinoma thyroid, because they decided that nahi, hum to alag hai, we are different. We have to go all the way into the blood vessels, cross connection. Similarly, all sarcomas decided we will go into blood vessels, but there are 2 exceptions out here also, and those 2 exceptions were rhabdomyosarcoma. So remember, rhabdomyosarcoma, they have the word sarcoma, but they are not going into blood vessels. And the other one is synovial sarcoma. Rhabdomyosarcoma and synovial sarcoma, they decide we are not going into the blood vessels. Hum ulta, we will go somewhere ulta. We are going to go all the way into the lymphatic channels. They will do a cross connection. Can everyone see the cross connection happening? Repeating, all carcinomas lymphatic except renal cell carcinoma, hepatocellular carcinoma, follicular carcinoma, those go into the blood vessel. Similarly, all sarcomas go into blood vessel, but rhabdomyosarcoma and synovial sarcoma decided I will go into lymphatic channels. Everyone's understood the cross connection? Okay. The next 2 route of spread, body cavity, body cavity. Both of them are body cavity, body cavity. Do you know what is a body cavity? Pleural cavity, pericardial cavity, peritoneal cavity. These are all body cavities. If the cancer says, now cancer is smart, cancer has 2 things. See, there are 2 kind of road trips that you do. एक तो होता है that you have just decided that we have like 5-6 hours off from duty. Let us just go roam around. We will stay on the road. We will roam around on the road and we will sit on any local roadside food vendor. We will have good tasty food. We will sit and roam around basically on the road only. There is no destination to it. That is one thing. So basically you're on the road, living on the road, eating on the road, that kind of a road trip. Second road trip is that you're only going like from Delhi to Mumbai. You have decided that I'm going to take that new expressway that has opened. So you decided to take the road trip because ultimate destination is from Delhi, ultimate destination is Mumbai only, right? So 2 things. One trip is where you're living on the road, and the other trip is when you're using the road to reach somewhere else. So when I say you are living on the road, you are sitting in the body cavity. Body cavity is the road over here. You are sitting in the body cavity. That example is pseudomyxoma peritonei. I'll explain this to you. What is pseudomyxoma peritonei? Pseudomyxoma peritonei, which body cavity am I talking about? I am talking about the peritoneal cavity. And which cancer has gone? Why am I saying myxoma, pseudomyxoma? So either it is the mucin secreting appendix cancer, either it's the appendix cancer, or it is the mucin secreting ovarian cancer. These 2 cancers have gone into the, either of the 2, jo bhi patient ko hai, either of the 2 have gone into the peritoneal cavity. So I say that basically they have gone and sat in, ye road, wo wala road trip hai where you're sitting on the road, eating on the road, everything you're doing on the road only. You have not gone anywhere, no destination, just roaming around on the road. So you have come and you have sat on the road. In the peritoneal cavity, these cancer cells decided that we are going to come and sit sit on the peritoneal cavity, pseudomyxoma peritonei, direct seeding of body cavity. That is number one. On the other hand, there could be another thing known as transcoelomic spread, where you are using the road from Delhi to Mumbai, you are using the road just to reach somewhere else. Means, for example, there is someone suffering from stomach cancer, because stomach cancer is the best example. Stomach cancer cells decided our ultimate destination is the ovary. Ultimately, we have to go to the ovary. How should we go? They will just go via the body cavity, means they have gone via the peritoneal cavity. Just a road trip where road is being used. Have they spent any one night on the road? Have they sat on the road? No, they are just using the road to reach where? Via the body cavity, they want to go to the ovary. So that is transportation ke liye. Transportation ke liye they are using the body cavity. That is a transcoelomic spread. What is this situation known as? When any cancer goes to the ovary, what is that condition known as? Krukenberg tumor. This is referred to as the Krukenberg tumor. So repeating once again, either the cancer cells will go and sit in the body cavity, example pseudomyxoma peritonei, or the cancer cells will travel through the body cavity. They will travel through the body cavity and ultimately go and sit where? They will ultimately go and sit into the ovary. So they are just using it for travel, and that is a Krukenberg tumor. Anything coming to the ovary, be it stomach cancer, be it colon cancer, be it breast cancer, be it pancreatic cancer, any cancer coming to the ovary is going to be Krukenberg tumor, but the most common is stomach, and that is why I gave you the example of stomach cancer for Krukenberg tumor. However, listen to this line very carefully. Now in gynecology, you will study that for Krukenberg tumor, there are a lot of theories coming up that Krukenberg tumor is not transcoelomic. They're also saying it is retrograde lymphatic spread. So kuch updates hain which are ongoing, but yeah, these are the four main routes that you can say: lymphatic, hematogenous, body cavity, body cavity. Everyone's understood? Now I can move forward. Which are the tumors which particularly say Goa to jana hai, but Goa maybe they have that one particular beach where they have to go. They have to go. So they say we have to go, but we have to go to bones only. Which are the tumors which go to the bones or which show bony metastasis? Public toilet. Public toilet means, quickly analyze with me what are the organs coming to your mind. Prostate cancer, you se kuch nahi hai. Next is breast cancer. Next is going to be lung cancer. Next is intestine cancer. Then what K organ comes to your mind? Kidney cancer. And finally T for thyroid cancer. These cancers have decided that we will always go to the bone. Okay, so they have gone to Goa. Goa mein also they've gone to that one particular beach where they wanted to go to. They've gone there. After going there, what will they do? After they have gone to the bone, prostate, breast, lung, intestine, kidney, thyroid, what do? Either they are going to, there are two types of people. One are extrovert people who have a blast. One are introvert people who just keep doing their own work. They don't mingle around with others. So same way, after going to this bone, what is the cancer going to do? Either it will start making new bone, means osteoblastic. Osteoblastic means it will start making new bone, or it will start breaking the bone. So means either it could result in osteoblastic reaction or it can result in osteolytic reaction. So remember, jo first wala hai, that is prostate, is usually going to show you osteoblastic metastasis. Then pick up the next two. The next two that you have are breast and lung. Breast and lung can show you dono. So dekho, I picked up dono tumor na. Breast and lung I have picked up dono. So this is going to show me dono response. It is going to show me blastic as well as lytic. And finally I say that whatever is left is only going to be lytic. So I have divided this public toilet into one tumor, two tumors and three tumors. So one tumor, then two tumor and three tumor. 1, 2, 3 mein divide kara. The first one, P looks like a B. So prostate cancer is going to show you osteoblastic metastasis. Then the next two, dono, both, breast and lung can show you blastic. Dekho, breast and lung can show you blastic and lytic. Ho gaya na yaad? Honestly telling you, this is impromptu mnemonic. Breast and lung is going to be blastic and lytic. Dono, right? And whatever is left after that, that is going to only be osteolytic. How simple, right? So this is done with the pathways of metastasis. That also means you are done with all the features of neoplasia that you had to know. The next part that you start off with are the fundamentals of neoplasia. The fundamentals of neoplasia. Don't get scared. Don't run away. I know it's a long list. I will make sure that you learn it in the simplest manner possible. Let's start. The first one that I have is self-sufficiency of growth signal. Basically, tumors or cancers say that we are self-sufficient. We don't need the human body. हम अपना देख लेंगे. We will do our own. I will make my own blood supply. Cancer says I will make my own blood, my own mutations, everything. So how has it become so self-sufficient? Fundamental number one, how has it become so self-sufficient? With the help of mutations. It has basically undergone a lot of mutations, and that is how it has become so self-sufficient. So now, unfortunately, there's a long list of mutations, but I promise I will give you the best mnemonics possible. Remember, whenever we are talking about PDGF beta, whenever this beta word comes, whether it is PDGF beta or it is PDGF receptor beta should remind you of brain tumors. Beta should remind you of brain tumors, particularly of astrocytoma. So please remember beta brain tumor. Next is HST. The way you say HST, so instead of HST, can you now convert it into OST? Because which is the cancer that happens with HST mutation? Osteosarcoma. So HST ka OST, osteosarcoma happens. Whenever there is HGF mutation, what is HGF? HGF is hepatocyte growth factor. Do I need to tell you what is the tumor that is going to occur? When we talk about hepatocyte growth factor, of course there is going to be hepatocellular carcinoma with the mutation. You think the examiner is going to give you such kind of a question? You wish. It's not going to happen. So examiner will ask you, hepatocyte growth factor is also known as what? Hepatocyte growth factor is also known as scatter factor. That could definitely be a question. That scatter factor mutation results in which tumors? You should know scatter factor is hepatocyte growth factor. That is going to have HCC. Next, EGFR1 and EGFR2. So देखो, EGFR1 and 2. 1 is alphabet A, 2 is alphabet B. How simple? A wala is going to cause adenocarcinoma lungs. So there is going to be EGFR1 resulting in mutation resulting in adenocarcinoma lung. EGFR2, 2 is which alphabet? B. This is going to mutation is going to result in breast carcinoma. This is going to result in breast carcinoma. In fact, EGFR2 is also known as HER2/neu. So now you can never forget, because everyone knows that HER2/neu is associated with breast cancer. Na? So EGFR2 and HER2/neu is the same thing. So simple, EGFR1 hai to A, adenocarcinoma lung. EGFR2 hai, second alphabet is B, breast cancer. Now let's come to RET. For RET, I want all of you to learn one rhyme. And that rhyme is RET 10 med men. What is RET 10 med men? That basically means that RET is the name of the gene. It is present on chromosome number 10. Which cancer does it cause? It is associated with medullary carcinoma thyroid. And what is the men part of it that I'm talking about? Men is the syndrome. It is associated with MEN2A and MEN2B. Repeating once again, when I say RET, we have RET 10 med men. RET 10 med men matlab RET is the gene, 10 is the chromosome, med is the medullary carcinoma thyroid, and men is MEN2A, MEN2B. So RET bhi ho gaya, RET 10 med men. So simple. Now I'm left with KIT and ALK. I'll take it on a separate slide. When I'm talking about KIT, I think everyone knows that c-KIT is also known as CD117. And whenever I go to play a game, I always carry a kit along with me. है ना? Whenever we go to play a game, I'm always going to carry a kit. So games is your mnemonic, because whenever some games tumor is seen, you will have to carry a kit. And games में क्या करते हो? Like football, basketball, you keep running around ना? Games is all about running around. Cricket में running around. So you are gonna run in this mnemonic also. I'll tell you how. G for was simple. Starting में no running around. Starting में steady. Play steady. Defense, that is gist. G for gist. Now start running. A से क्या है? You will say, ma'am, some leukemia. AML था, ALL था. I can't recall. तो run, go to the next alphabet, pick it up. Which leukemia? AML होगा. ठीक है. Next disease with M. अब M से कौन सा disease? I'll say run back. MA. Is there any disease with MA that you know? Mastocytosis happens with MA. Okay, run forward. ME. Is there any disease with ME that you know? Yes, there is going to be melanoma. Okay, then again run backward. What is the disease of SE? SE is going to be seminoma. So imagine, just AML, mastocytosis, melanoma, seminoma. These are all the tumors that are going to be affiliated with kit, C-kit. So remember, whenever you go to play a game, you are always going to carry a kit along with you. Okay? Now coming to the last one, that is ALK. Again, A for A, guys. This is associated with A for adenocarcinoma lung. So, सबसे पहले A for adenocarcinoma lung. There's another A, anaplastic large cell lymphoma. Go to your lymphoma chapters, you will study anaplastic large cell lymphoma is going to show you A for A, that is ALK mutation. One thing I want to tell for students who are preparing for higher institute exams, please note ALK is also associated with inflammatory myofibroblastic tumor. ALK mutation is associated with inflammatory myofibroblastic tumor. That is important. So repeating, when I say ALK, ALK for adenocarcinoma, ALK for ALCL, and ALK for inflammatory myofibroblastic tumor. Finally, this entire list is done. This with c-KIT and ALK, this entire list is done. The story is not over. Now we come to the mutations that are to do with RAS. So there are three types of RAS molecules. There are three types of MYC molecule that are there. So firstly, RAS. What are the three alphabets for RAS? KRAS, HRAS, NRAS. How will I learn it? Whenever you have to ask someone, like GPS nahi hai, you want to ask someone for the way, what do? Rasta kahan hai? Rasta kahan hai? This means you have KRAS, HRAS, NRAS. That is how we say Rasta kahan hai? KRAS, HRAS, NRAS. What are the mutations? KRAS mutation is seen in Kapil tumors. What are Kapil tumors? So K for, we will write it down as K for colon cancer. Colon cancer, then Kapil mein P for pancreatic cancer and L for lung cancer. So please remember KRAS for Kapil tumor, colon, pancreas, lung. HRAS, HRAS mein what are you going to do? You're going to make a diagram. Matlab, H say first and foremost I can make a kidney out of it. This is associated with renal cell carcinoma. Renal cell carcinoma, renal ke niche urinary bladder, the urinary bladder cancer. So one thing that I made was the kidney and the urinary bladder. The other side of H, I am going to convert it into a P because this is rare but important. This is associated with pituitary carcinoma. This is associated with pituitary carcinoma. So repeating, there's HRAS, which is renal cell carcinoma and bladder cancer. Then there is P for the pituitary carcinoma. Now coming to N. N is everything to do with M. That is going to be AML and that is going to be melanoma. AML and melanoma. So N is with M and M. हो गया याद? So firstly, रास्ता कहाँ है? KRAS, HRAS, NRAS. KRAS is Kapil tumors, colon, pancreas, lung. HRAS is kidney, bladder and pituitary carcinoma. And NRAS is AML, MM wala melanoma. Now we come to the three types of MYC. What are the three types of MYC that you have to know? So remember, for MYC you will learn colon, C.L.N sounds like colon, C-MYC, L-MYC, N-MYC. The three numbers or alphabets that you have are C-MYC, L-MYC, N-MYC. Where is N-MYC mutated? N-MYC is N for N. It is mutated in neuroblastoma. N-MYC is mutated in neuroblastoma. Where is L? Some kind of L for L, na? L-MYC mutation, amplification, lung cancer. कौन सा lung cancer? With lots of L's. Small cell lung cancer. And finally, C-MYC. C-MYC is the childhood wala lymphoma. C for C. Childhood wala lymphoma is what? Bachcha lymphoma, Burkitt's lymphoma. Bachcha lymphoma, Burkitt's, child lymphoma. So yes, remember C for child, Bachcha. So Burkitt's lymphoma. L for small cell lung cancer. And N-MYC is going to be for N. That is neuroblastoma. So MYC is also done. And the kaha, rasta kaha, so KRAS, HRAS, NRAS is also done. Almost coming to the end, guys. Where do you see the presence of ABL? This I don't feel like asking you only. Everyone knows. Where do you see BCR and ABL fusion? BCR and ABL fusion is seen in translocation 922. Translocation 922 causes BCR ABL fusion, means which leukemia am I talking about? We are dealing with a case of CML. So if they ask you what is it about ABL, you should be knowing ABL is to do with BCR ABL. Next, what do you have with BRAF? BRAF is, I always say BRAF is NEET PG students or FMG students or INI, basically medical entrance exam students, koi bhi exam ho. Because you have to do so much of multitasking. You have to do PYQs, then most important topics, then volatile topics, then now you have choti copies also, and now you have 20th notebook, images alag, so many things, platforms, so much. So firstly, hats off, huge respect. And secondly, you guys are brave. Why do I say that? Because BRAF mutation can result in a total of 6 tumors. So I'll divide it into groups of 2. Okay? So first and foremost, BRAF mutation can cause hairy cell leukemia. If you read it from left to right, it is hairy cell leukemia. If you read it from right to left, Langerhans cell histiocytosis. So hairy cell leukemia and Langerhans cell histiocytosis. Okay? One set is done. Okay. Next you have PNP, papillary carcinoma thyroid. So thyroid shows you BRAF mutation. And juvenile pilocytic astrocytoma, brain tumor. So one thyroid tumor, one brain tumor. Next, other than that, we have colon cancer and we have melanoma. We have colon cancer and we have melanoma. So repeating once again, hairy cell leukemia and LCH, PCT and JPA, so PNP and colon and melanoma, these are all going to be the BRAF mutation. So you guys are BRAF. Finally, cyclin D mutation is seen in a lymphoma known as mantle cell lymphoma. Very important point. And how do they ask you the question? They ask you, mantle cell lymphoma shows you which mutation? Cyclin D, E, A, B. So now you should know that mantle, how have we learnt it? We have learnt it as mantle, mental, dumb. We have learnt it as mantle, mental, dumb. So mantle sounds like mental and mental is dumb. So kaunsa cyclin? Cyclin D is mutated. And on that note, you will suddenly ask me, what is cyclin D? So I will say, this is a cell cycle. Should we finish off the cell cycle also? Jaldi should I tell you the most important points of a cell cycle? Because now mutations are done. This first fundamental is over. I've told you all the mutations that have made the cancer self-sufficient. Now I need you to know what is it about this cyclin D? Ye cell cycle kahan se aaya? So first I will start with the cell sleeping. This is the quiescent, the inactive, the sleeping stage, right? This is the inactive stage of the cell. Now let's make the cell work. So the first stage that it comes into is going to be G1, then S, then G2 and M. Guys, the first thing in the exam they will make you do, sequence mein lagao. Put it in the sequence. G1, S, G2, M. Please note their timings are also important. So tell me something, because many students mug it up, then forget, then mug it up, then forget. And I will tell you a way that you will once learn it and never forget. Ek baat batao, you guys, and all of us are guilty. I am also guilty of doing this and I'm sure you are as well. Do you have, as a medico, do you have any particular sleeping time and waking time? Like I will sleep at 10 p.m. and I will wake up at 6 a.m. every day. Aisa kuch hai? Nahi na? There are so many factors, exams, web series, what am I watching, what am I binge watching, where am I partying, or am I just sitting and doing nothing but I'm not sleeping? So many factors. We have no sleep time, we have no wake up time. Same is our cell cycle. If they ask you that, is there any sleep time or is there any wake up time? No, sleeping time and wake up time is totally variable. G0 and G1 are variable. However, all the other time of the day is sorted. 6 hours, 4 hours, 2 hours. How simple. So they ask you, which are the phases of the cell cycle which have a variable time? Remember, those phases of the cell cycle are sleeping and waking time. There is no sleep time, there is no wake time. Just like medicos, G0 and G1, there is no time limit, but others are 6, 4 and 2. Okay? Now tell me, which is the most radiosensitive part of this cell cycle? So remember, the most radiosensitive part is going to be G2M. But if they ask you least radiosensitive, so remember, least radiosensitive is going to be the S phase. The least radiosensitive is S phase and the most radiosensitive is G2M phase. Which is the point of no return? That is also S. This is the point of no return, means if the cell crosses this, you can't get it back. There is no reversal, because S for what? Synthetic phase, na? Synthesis has occurred, DNA synthesis has occurred, and once the DNA synthesis will occur, then there is no coming back, of course. So repeating, G1S, G2M हमने cycle करा, G0 and G1 are variable timing, no sleep time, no wake up time, others are 6 hour, 4 hour, 2 hours. Most radiosensitive is G2M, the least radiosensitive is S, and the point of no return is also going to be S. So now that you've spoken about radiosensitivity, can you tell me all the radiosensitivity questions in the body? Number 1, the most radiosensitive phase of the cell cycle was G2M and the least radiosensitive phase of the cell cycle was S. This we studied. Now if I ask you which is the most radiosensitive tumor overall in the body, your answer will be Ewing sarcoma, the bone tumor. But if I say which is the most, I add particularly asking most radiosensitive testicular tumor, then your answer will be seminoma. So read the question carefully. Have they asked me the overall most radiosensitive tumor or have they asked me the testicular tumor? Next, the least or the most radiosensitive cell. So the most radiosensitive cell that we have in the body is going to be a lymphocyte. And the least radiosensitive cell that we have in the body shall be the platelets. Again, these are one of not just cell cycle questions, I will say these are all the radiosensitivity questions that you have. Tumors, cells, cell cycle, everything covered. But coming back to the cell cycle, I told you the cell cycle works like this: G1S, G2M, G1S, G2M. Why? Because now I will tell you Dhoni ek acha batsman. What is Dhoni ek acha batsman, which is very nice thing that we have to know. So sabse pehle, the cell cycle keeps on moving G1S, G2M because I am actually making it move like that. Who is making it move like that? There are some things called cyclins and CDKs. All of you can see cyclins are in the form of alphabets, CDKs are in the form of numbers. So they work together. ये एक साथ काम करते हैं. But if you start learning cyclin D, CDK4/6, cyclin E, CDK2, cyclin A, CDK2, cyclin B, CDK1, so much of confusion will happen now. Which alphabet, which number? So I had to make a mnemonic. So remember, what is Dhoni ek acha batsman? So that means it is DEAB. What is the sequence of the cyclins? DEAB. So if you don't know Hindi, then it is Dhoni ek awesome batsman. Okay, either way, Dhoni fits in everywhere. Hindi, English, everywhere. So remember, Dhoni ek acha ya awesome batsman, DEAB. And what does Dhoni do? Dhoni to hits 4s and 6s, na? So what are the CDK numbers with Dhoni that you will keep? With Dhoni, you will keep 4 and 6. And for the others, you will keep double, single. Okay, double, and single. So 4, 2, 2, 1. 4, 6, 2, 2, 1 is how I learn it. Repeating. First, you will write that, okay, cyclins hai. Cyclins mein Dhoni ek acha batsman, DEAB. And CDKs mein Dhoni ke saath I will always keep the 4s and 6s. And for the others, I will do the double, and the singles. Simple, guys. I hope everyone's mugged it up. Very easy. This order is asked in the paper and that is how the cell cycle is working. This finishes off your first fundamental, which was self-sufficiency of growth signals. Now I'm going on to the second fundamental, which is inactivation of the tumor suppressor genes. We are going to make a list of all the tumor suppressor genes, their chromosomes and their diseases. Cancer says that you have tumor suppressor genes, you have genes which are protecting you. Hang on. Cancer says, I will chuck them out. I will inactivate them. So what are the tumor suppressor genes? It's a long... First, I'm just telling you the names of these tumor suppressor genes. Forget this inactivation. First, just think of tumor suppressor genes. So can you tell me the names? When I talk about the policeman that is P53 is present on chromosome 17p13. 13 से ही continue करो because the next one, that is governor. Who is the governor? RB gene. That is chromosome 13q14. Let's do a repeat of this. I'll tell you once again. Policeman कैसे start करा? You said chromosome 17p13. From 13 only you continue and you say, okay, RB gene is 13q14. Next, coming to all these 1, 2, 1, 2, 1, 2 wala combination. NF1, NF2, BRCA1, BRCA2, WT1, WT2. So NF, count what is neurofibromatosis. You know how many alphabets this has? Some really Vela person in life sat and counted it. It has 17 alphabets. Chromosome 17 is NF1 and NF2 is 2, 2, 22. NF2 is going to be 2, 2, 22. So repeating, NF1 is going to be chromosome 17 and NF2 is going to be 2, 2, 22. Coming to the next, that is BRCA1 and BRCA2. Remember, BRCA1 is also chromosome 17, but BRCA2 change ho jayega. BRCA2 is going to be chromosome 13. So remember, for NF1, NF2, you had to learn 17 and 22. For BRCA1, BRCA2, you will learn 17 and 13. Bas yahi difference hai. 17, 22, 17, 13. ठीक है? For WT1, the way you write W looks like an 11. So you will say that Wilms tumor wala, WT1, WT2, both of them are present on chromosome 11p because W looks like an 11. So both of them on 11p. Next, talking about P10. 10 to sabse simple. This is present on chromosome 10. Wow, I wish this comes in the paper. P10 gene is on chromosome 10. APC. This you will have to mug up. APC is present on 5q21. And I hope you all remember, I will be teaching you in GIT again that APC is associated with what? It's associated with a disease called familial adenomatous polyposis. Finally, CDH. CDH ka actually the chromosome is 16, but you don't have to know, you just have to know CDH stands for E-cadherin, and that is more than enough. So numbers ho gaya. I hope everyone's done the numbers. Let's do a very quick recap. P53, 17P13, wahi se continue kara, 13Q14 is for RBG. NF1, NF2 are 17 and 22. BRCA1, BRCA2 are 17 and 13. WT1, WT2 same chromosome 11P. APC is on FAP, तो FAP के साथ 5 chromosome. P10 is 10, so chromosome 10, and CDH stands for E-cadherin. Out of these, question 1. Till now, these were all your normal good people. They are fighting for you. Cancer comes and says, I will chuck them out. Inactivation of tumor suppressor gene is what I'm going to do. So imagine it goes and inactivates your P53, your policeman. What is that known as? When there is a mutation in P53, it is known as Li-Fraumeni syndrome. I hope you all remember from genetics, Li-Fraumeni syndrome is an autosomal dominant disorder. Please also note that Li-Fraumeni syndrome, when a patient has Li-Fraumeni syndrome, the patient ends up having all the BB tumors in the body. What is BB tumors? The patient will have bone cancers, the patient will have blood cancers, the patient is going to have breast cancer, and the patient should also have, so we are talking about all BB na, so a brain bacha. So that is going to be the brain cancer. So remember, if there is someone having blood, bone, breast, brain, these cancers in the family, if BB tumors will occur, that person is probably having Li-Fraumeni syndrome. Tell me a question from surgery and medicine. Tell me what criteria is followed for Li-Fraumeni syndrome. I hope you remember it's the Chomprette criteria. The Chomprette criteria is followed for Li-Fraumeni syndrome. Very important. So repeating, P53 ka mutation, Li-Fraumeni syndrome, BB tumors, Chomprette criteria. P53 is done. What about the next one, the governor? Like I said, who is RB gene? RB gene is known as the governor. And have we done the chromosome? It is present on 13Q14. There is a chota sa one-liner that I want you to learn over here, and that is RB gene normally does not have any phosphorus. The normal form of RB gene is hypophosphorylated. I hope all of you remember this from the main videos. I gave you a very nice story. It's obviously a detailed thing, but there's a very nice story of how there's a breakup and a patch up and how there's revenge involved in it. So in case you've not, you can get back to the main videos definitely and see it, but that will be a really long thing to cover in rapid review. I don't want to get into so much of detail, but I've given you the recall point. How is normal retinoblastoma gene present in your body without any phosphorus? It has no phosphorus in it. It is a hypophosphorylated form. So tell me something. If the retinoblastoma gene gets mutated, if there is a retinoblastoma gene mutation, you will not get even a single point for guessing that the tumor that it causes is retinoblastoma. The tumor that it causes is retinoblastoma, but for this mutation, is one hit enough? No, this mutation has to be a 2-hit. This is known as Knutson's 2-hit hypothesis. This is a Knutson's 2-hit hypothesis that it follows. That is the retinoblastoma tumor that is going to occur. Please note that retinoblastoma is now going to be of 2 types. Either it can be running in the families, or it cannot be running in the families, which is sporadic, out of which of course the sporadic one is the more common one. So either it is running in the families or it is not. When it is running in the families, it is involving both the eyes. It is involving both the eyes when it's running in the families. Not only that, not only is it a bilateral retinoblastoma, but it is also at a risk of something known as pinealoblastoma. What is pineal gland? Do you know pineal gland? Medical में pineal gland होता है, but Hindu mythology में pineal gland is known as that शिवजी की तीसरी आंख. So imagine people who have familial retinoblastoma, how many tumors do they have? 3 tumors. 2 tumors तो eyes का होगा, 2 tumors तो retinoblastoma, 1 tumor is the third eye, so that is pinealoblastoma. Together this situation is known as a trilateral retinoblastoma. Together, this situation is known as a trilateral. So no one has had 3 eyes all of a sudden. It's just a way of saying 3 eyes matlab 2 to eyes hai, retinoblastoma, and one is the third eye, which is the pineal gland. So there is a risk of pinealoblastoma, and that is what makes it 3 tumors, and that is trilateral retinoblastoma. Very important. Any other thing that it is at a risk of? Yes, there is also an increased risk of bone tumors, and that bone tumor is going to be osteosarcoma. There is also a risk of osteosarcoma. If you can learn that, amazing. Sporadic में ऐसा कुछ नहीं है. Sporadic is just involvement of one eye. There is no 2 eye involvement, no third eye involvement, no other thing. All these problems are to do with familial wala. Both the eyes will be involved and third eye will also be involved. You will call it trilateral. Then bone tumors can also occur. सारा problem familial का है. Sporadic में only one eye, and that's about it. That is what you need to know about retinoblastoma. Coming to the next gene, what did you study about P10? Which chromosome was it on? P10 gene was on chromosome number 10, isn't it? So please remember, P10 is going to be chromosome number 10 as we have studied. And now I will tell you one aisa rhyme. Rhyme matlab P10 is the gene, chromosome 10 is what it's present on. And what syndrome does it cause? It is associated with Cowden syndrome. P10, chromosome 10, Cowden syndrome. So kya hai? What does Cowden syndrome have? Again P10. Mnemonic is also P10. So P10, chromosome 10, Cowden, and come back to P10. P10 tells me that one tumor that it's going to have will be endometrial carcinoma. N stands for endometrial carcinoma. The next one is going to be T. What is T? T is going to stand for some kind of thyroid tumor. T is going to stand for thyroid tumor. T is also going to stand for a skin tumor known as tricholemoma. It is also going to be associated with tricholemoma. Coming to the P's, there's one P straightforward which says that P say intestinal polyps hoga. And now I'm going to do a little bit of change of the P into a B because these patients also have breast cancer, and that finishes off Cowden syndrome. What is Cowden syndrome? Cowden के साथ P10 याद रखना. P10 chromosome 10 Cowden. N for what? N for endometrial cancer. T for thyroid cancer. T for tricky. Tricky मतलब hair. Tricholemoma, hair का tumor. P for what? P for polyps. And what else? P का B बनाया. So breast cancer is also gonna occur. That is what you had to know for the P10 gene. The last gene that I want to teach you is what? The CDH gene. Did I just tell you what does CDH stand for? CDH stands for E-cadherin. Cadherin, CDH, E-cadherin. It is glue, cell-to-cell connection. How is E-cadherin working? E-cadherin is basically responsible for this cell-to-cell connection. So, students call it glue. Okay, ma'am, Fevicol hai, glue hai. So now when the glue will go away, when there is loss of E-cadherin or mutation of E-cadherin, whatever you want to call it, glue chala gaya. The glue is gone. Which tumors will happen? When the glue is gone, remember, when the glue is gone, which tumors will occur? Glue ka golu ho jayega. Golu tumors are gonna occur. When the glue is gone, the golu tumor occurs. So golu matlab gastric and lobular. The golu tumor. So one is a gastric, that is diffuse gastric cancer occurs, and one is a tumor of the breast. What tumor of the breast? Lu wala, lobular carcinoma breast. So repeating, when the glue will go, golu tumors will occur. Gastric cancer will occur, lobular carcinoma breast will occur. Yaad rahega? Gastric cancer will occur, lobular carcinoma breast will occur. This is also sorted. So done with the first fundamental of all the mutations, done with the tumor suppressor genes. The third fundamental says the cancer will keep on dividing, limitless division. वो तो obvious है, cancer है वो. It is going to divide forever. How does it divide forever? Because it has something known as telomerase. It has a lot of telomerase. That is why it will keep on dividing. Next, they say that the cancer will never ever die. It will escape apoptosis. Of course, it is never going to die. It will definitely escape apoptosis. How? By increasing anti-apoptotic mechanisms. Can you recall from chapter 1 what are the anti-apoptotic factors that you have? So these were what? all the LLL wala molecules. Like example, I'll give you one of them, BCl2. So yes, it is going to increase all the LLL wala molecules and it will say, I'm not going to die. Cancer though is very smart. It says, I will keep on dividing forever and I am not going to die. Further, cancer says, Ruko, wait, I am going to make my own blood supply also. Cancer cells, I am going to do angiogenesis also. Next, cancer says, I will jump into that blood vessel and go on the Goa trip. I will have invasion and metastasis, which I have taught you. Cancer also wants to do metastasis. Finally, cancer says, I am going to mess up with your DNA as well. No matter what you try to do, I will mess it up. So now the cancer says that I will cause DNA repair defect. So divide this topic into two parts. Think of DNA repair pehle. What all God has given me for DNA repair. Then I will mess up all of that DNA repair and then I will come to the defects. So please note, God has given you nucleotide excision repair genes, NER genes God has given you. Then God has given you mismatch repair genes. Then God has given you homologous recombination. God has given you these three mechanisms that if anything will go wrong in your DNA, I will come to your rescue either by nucleotide excision repair genes, that is NER, or by mismatch repair genes, that is MMR, or by homologous recombination. So now you say that, ma'am, I was very happy till my DNA was repairing. I was very happy. Cancer ne aake happy sad kar diya. Cancer has converted it into sad. Cancer is saying that now there is going to be a defect. All the good people are going to go. So if there is a defect in NER, so remember, nucleotide excision, isko ulta padho, excision, read the excision opposite, XE. So that is going to be a disease called xeroderma pigmentosum. That is a disease called xeroderma pigmentosum, and xeroderma pigmentosum is associated with a lot of skin cancers, basal cell carcinoma, squamous cell carcinoma, lots of skin cancers. So remember, nucleotide excision ka opposite pada, I got XE, xeroderma pigmentosum. Simple. Next, when I'm talking about mismatch repair, if the mismatch repair genes undergo a defect, there is a disease called hereditary non-polyposis colon cancer. Hereditary non-polyposis means no polyps, colon cancer. Now remember, is there any other name for hereditary non-polyposis colon cancer? Ye short form to pata hai sabko. Hereditary non-polyposis colon cancer. This is also known as the Lynch syndrome. So remember that syndrome, you'll say, ma'am, syndrome matlab lots of things. Syndrome, CEO has gone for lunch. CEO has gone for lunch means colon cancer, endometrial cancer, and ovarian cancer. What are the three cancers that are going to happen in Lynch syndrome? So CEO has gone for lunch. Colon cancer, endometrial cancer, and ovarian cancer is going to happen. So I will learn that CEO ke saath, you know, the boss, you are never going to get along with your boss. Common sense. Everyone has a problem with their boss. So CEO ke saath to hamesha mismatch hoga. With CEO, there's always going to be a mismatch. So as soon as you learn CEO has gone for lunch, you'll say, okay, Lynch syndrome matlab there's a mismatch with my CEO, mismatch repair gene problem. And finally, when there is a homologous recombination problem, there are three things that can occur because of this. Either that is known as Fanconi anemia. So one condition, Fanconi anemia. Next is going to be the Bloom syndrome. And the third one is going to be the ataxia telangiectasia. So these are the three problems that